So we're just, oh, we're recording. Yes, we will try to remember to record. So, we're just finishing up our opening and goals. Today, we've got about 9 different sessions. So we'll be starting with C-CDA Challenges around documents with no sections. Then that's with Brett Marquardt and the VA folks. Catherine will be talking about interoperability for lab data. And as a few people mentioned, they were looking forward to that. And then Gay and Brett are going to talk about the updates from USCDI V5. There's a lot of work going on around understanding, what the new elements in USCDI V5 are and how they're going to get incorporated into CCDA 4. So that's going to be a good topic. Jim and Dennis are going to do an Eyecare specialty data update, an update on that guide that has been presented for the last 2, I think. And we've had some tracks on that, so that'll be good to see. Then we've got Lisa Nelson and Catherine Lusk again talking around maternal health clinical needs. So that's a new specialty data, so that'll be interesting. In the after the break, there's an update on the FHIR Profiles project that's going on. We've got a long range roadmap from CMG. Lisa Nelson will be talking about that. Linda and Brett, again, because we love Brett, will be talking about insurance coverage. Then the one that everyone loves.
What's that say about me?
We love you too, Linda. I'm just pointing out that Brett's on the agenda 3 or 4 times. So, ONC presentation and the ONC question and answers. Everyone loves that. So that's, that'll be great. And then closing recap. That's for day 1. So we got a lot of things going on. On day 2, Dee Dee's going to talk to us about the Sequoia data usability. Then we're going to have our breakout tracks. So we've got 2 breakout tracks, maternal health and validation. There may be more if we if we think of those. But normally, sorry, I'm getting pinged. Normally we stay with the 2 breakout tracks. There'll be after lunch an update on the CDA R2 online edition. And then we're going to have in the afternoon a breakout, and we're probably going to keep the 2 breakouts. Benjamin's going to be doing more validation. And for those people who want to help setting up their systems, I know last IAT, we spent quite a few time helping a few people, but I'm going to run a track where I can help people get set up, right? If you need to install Java, install other things, get your paths right, those kinds of things. If people want that, if no one comes to that, then we'll all be working on validation. And then closing. So I'm looking very forward to the agenda. We've got a nice jam-packed and a lot of good sessions. Like I said, the 2 different tracks, if discussion from day 1 says we need more, we've got room to have more tracks if we need. And the icebreaker is the vacation. So if you haven't sent your vacation photos to Susan, please do. Susan.rand@dogwoodhealthconsulting.com. And during the breaks, she's going to be showing some of our vacation pictures. So, all right, that's it for me. I will stop showing that, and I will stop sharing. And first up is Brett Marquardt with the C-CDA Challenges around no sections populated.
Hey, thanks, Sean. I feel like, I clearly, I can't take any credit for this particular topic other than connecting Teresa and Eden to this group. And so just a little bit of setup here is the VHE team approached me with a challenge they're having with getting empty CDA documents. And we had a really nice discussion on it on a separate call. And we thought, it was about 2 weeks ago, and we thought, no better place than to bring it here and get broader input than just get my opinion. And so with that, I don't know if Eden or Teresa is presenting. They have a really nice slide deck to kind of set the stage with about 10 minutes of prep and then open discussion.
Absolutely. Thanks, Brett. Right. Let me know when you're ready for us to go ahead and kick it off.
Do it.
All right. And you can see my screen?
Yep.
Yes. Excellent. Excellent. All right. So yes, as Brett mentioned, we're hoping to, get through these slides the next 10 minutes, kind of setting up that overview discussion and then really getting into a group discussion where we'd love everyone's feedback. So my name again is Teresa Saxon. I am a member of the Veterans Health Administration VHE Clinical Data Quality Team. I am also a registered nurse by background, and joining us all the call today is also Eden, who you heard introduce herself as well. She's a member of the content management team and also a background in nursing. Together, like Brett mentioned, we've developed this presentation to discuss data minimums specific to C-CDA templates. So over these next few slides, we'll be covering 2 use cases and some proposals on how we can be smart senders and resilient receivers. The first use case that you're seeing here really focuses on data minimums across all C-CDA templates. And then the second use case that we'll get into focuses specifically on those progress note document templates. And before we get started, again, I'll mention that we have plenty of time at the end to have questions and discussion for everyone on the call. And while I share my screen, I probably won't be able to see the chat as actively. So please, Brett and Eden, I'll have you guys let me know if I need to pause at any time as well. So first, we'll go over our first use case where we're talking about data minimums across all C-CDA templates. Here we're seeing a provider where they're opening a C-CDA and it's only containing those patient demographics data, no clinical data present in any section. And this is a topic we've heard and seen from our VA clinicians without, receiving meaningful or actionable data. And of course, it's a time waster, leaves the clinician frustrated. And so we were able to find some data to back up these clinician statements. And in 172 veteran patients we reviewed, 67% of those documents came across with no clinical data in any of those sections. So again, down below, you see this sample has across 11 different health systems, 6 different EHRs from 2022 to 2023. And so we thought about, maybe why is this happening? And to Brett's point, brought this to the HL7 affinity work group as a great discussion. And we talked about looking at the current requirements for various templates and just walking you through this slide quick. The CCD here is in blue. We're looking at anything that's required for these certain templates, focusing on, again, the CCD in blue, discharge summary template in green, and the progress note template requirements in pink. Anything that has kind of that color overlap is because it was required in both sections. And so, while these requirements are present, when we talk data minimums, we want to go to another level further in requirements. And at the VA, we've established a threshold, like a data minimum threshold, that we'll discuss in the upcoming slides as far as proposing ideas. And this slide also targets our second use case where we're targeting that progress note C-CDA template. And as you can see on the slide, there are notes that are not required here on that bottom. My arrow cursor won't go over to it, but that bottom left corner, that note section. And that's what the clinicians are really looking for at the VA. Again, we'll dig into these use cases further, but I'll pass to Eden to discuss some of our ideas on these topics.
Thank you, Teresa, and thank you, Brett, for having us here today. So discussing our first use case, we're going to be talking about data minimums for all C-CDA document templates. And on this slide, we've broken down the document into 2 sections, one being the header of the document and the other being the clinical sections of the document. On the right-hand side of the slide, we've identified all the items that are listed in the header. And although there's a lot of information in the header, we would consider a clinical document to have low to 0 clinical value if there is no clinical information included in the document. However, if there is clinical information in the document, we would obviously consider that to have higher clinical value. We would hope that a document that has only information in the header, we're going to make a couple of recommendations about how we'd like to deal with those types of documents when there is no data populated in the clinical sections. You can go to the next slide, Teresa.
Sorry, there's a little bit of a lag. There we go.
Okay. So in thinking about this topic, we're talking about it from a smart sender and a resilient receiver perspective. And so our recommendations are coming from both of those viewpoints. As a smart sender, we would like to ask that document creators shall only create and provide a C-CDA document when at least one of the clinical sections contains at least one clinical entry for the patient. And if the C-CDA document can only provide data in the header, but no entries in a clinical section, then we would ask that the responding organization shall not list the document in a QD response message. We've also considered the fact that date of death information is frequently included in the header. And while this is information that's important, we would still not consider only this information to be clinically relevant if that is all that is populated in the document. As a resilient receiver, we would propose that document receivers shall promote access to usable data by displaying the count of clinical entries per C-CDA document to the end user so that the user has an idea of what's actually available within the document. We would also propose that document receivers shall promote access to usable data by reducing or eliminating access to C-CDA documents where the number of clinical section entries is 0. So in essence, removing those documents in a list as being available for a provider. All right, moving to use case number 2, we're talking about data minimums for the progress note template. So within the C-CDA progress note template, there are some required sections, one being the assessment and plan, or the assessment and plan of treatment. In this section or in this document, there can also be the potential for provider notes or progress notes that could be available for users. However, these are not required as part of this template. We have found that users would really like to see progress notes of some type within this template to consider this type of thing clinically usable. Having an assessment and plan or an assessment and plan of treatment does not thoroughly illustrate the care that was provided for the patient and can leave providers feeling like the document is really not all that usable when they get it in a document list. So our proposals would be to make the notes section required for the C-CDA progress note template, or make the existing required sections, those being the assessment and plan or assessment and plan of treatment, to have a required note activity within them. We would also like those proposals to extend to the care quality and Commonwealth specs so that encounter summary documents shall contain a note section with at least one note activity entry, or shall contain at least one note activity entry in another section that has been included in this document. We do consider this to have higher clinical value when things like clinical notes or nursing notes would be included in this document in one place for providers to look at when they receive this information.
Awesome. So
Teresa,
thanks,
I
Eden.
think it's back to you. Thanks.
Yeah, that was excellent. Appreciate that. And I'll just go ahead and quickly summarize. Again, you've seen this slide. Just gonna recap again what we're seeing for both smart senders and resilient receivers before we open it up to discussion. Across all those C-CDA templates, we're really wanting at least one clinical section to be present. And then as a resilient receiver, as Eden mentioned, maybe populating how many clinical entries there are so that clinician can choose whether they want to open it or not. And then specific to those progress note C-CDA templates, we're proposing, everything that we just discussed, and then going one step further to adding those note section requirements Eden discussed. And again, more conversations with care quality and common, well, concise C-CDA. As a group, we're hoping to get everyone's feedback and open discussion, and hopefully we can continue evaluating and maybe implementing these ideas. So again, hopefully sessions like today will move the needle towards meaningful exchange, and we really appreciate everyone listening. Brett, I'll defer to you for how to handle, next steps. Do you want to go ahead and open it for discussion, or would you like to add anything in?
Thank you both. I think this was fantastic. I think folks know me well. I can't resist adding a few things in here. In terms
And I'm
of
happy
how
to go back a few slides if you need.
Yeah. So maybe I think the very second slide, or maybe it's the third slide with the kind of that one to me, I think is a good one to pause on for a moment. So maybe we split the conversation. We have about 15 minutes here. Maybe we split the conversation in two parts. The first part is about, these empty documents, discussion from everyone, like who else is seeing that? Why are they seeing that? And then maybe the second part on the kind of new requirements of the progress note. And then we can maybe kind of land on, next steps for both of those. So that's what I'm thinking. I see Lisa's hand went up.
Oh, trying to get faster on my mute there. Thank you, Brett. I just wanted to, in terms of terminology, there's an interesting conversation going on right now about the difference between structured documents and clinical documents. And I wanted to take a second to just agree. This is awesome information, and the work that you guys have succinctly presented here is amazing. But I think it's relevant for structured documents. There are clinical documents that provide a great deal of clinical value and should be considered highly valuable and relevant, and they have no clinical sections because they're not a structured document. They're a clinical document that has a header and a non-XML body. And so I just want to make sure that as we continue to refine and clarify all of this, that the focus is on documents which are structured documents. And that's really what you're talking about, not necessarily clinical documents, because there's many valuable clinical documents that you would want to receive through eHealth Exchange document query that have no clinical sections in them at all because they're unstructured, non-XML body types.
Thanks, Lisa. And correct, we're talking about CDA with kind of the structured sections, not the unstructured document or the C62, where you embed a PDF or embed another type of file here. So thanks for that clarification. I guess my curiosity is, I think we have Meditech, Epic, ECW, DHIT, some vendors who generate documents. And I think maybe I could pick on Ryan first, because Ryan may have at least thought about this a little bit. Ryan, can you talk a little bit about why you may generate a document with no clinical sections populated?
Yeah, we have pretty much two use cases for these two sets. The first would be an encounter, I guess the progress note, the encounter level document. We would only ever generate one of those if there is a related encounter. So that if there is an encompassing encounter, potentially we would then include any data that's documented on that encounter. So potentially we may not have a note to include, but we might have other encounter data that was generated during that visit that could be included in that encounter level document. So in that case, we will always have some data to put in that document, that encounter level document. It just depends on what was documented during that visit, the nature of that visit, what would end up there. The CCD, or the patient level document that we generate, that's one where we would more likely have cases where there might not be content in potentially any of the sections in that document, since we generate it on demand and it's constantly being updated with the patient's current status, current state of their most recent data.
Thanks, Ryan. Just a time check, John. I can already tell, like, this is going to carry for more than 15 minutes. What's next after this, and how flexible are we if we go 5 or 10 minutes over?
We gave you to the top of the hour. We actually gave you half an hour.
Okay. I'm just what I'm saying is I suspect this could carry beyond that. I'm forecasting.
Yes. Yeah, I mean, we've got a pretty much a hard stop. We got a bunch of topics. Sorry.
Okay. Then let's just cruise through. So we can cruise through. I think I didn't hear anyone from Oracle on the call, but is there anyone from Oracle Cerner on the line?
Nope, they're not
Okay.
attending.
Okay, Richard from ECW, do you guys ever, yeah, I know Meditech and ECW are on. Richard from ECW, do you guys ever generate empty encounter summary documents, and when would that happen? And
I don't think that would be a real use case, Brett, because usually our encounter summary documents are, through common healthcare quality workflows where they're asking for an encounter summary document. We're sharing that unless there is, a query that came in before the document, before the progress note was really documented. But other than that,
okay,
other than
thanks,
that, I
Richard.
think we should have some data in the clinical sections.
Thanks, Richard. And I think was it Kyle from Meditech? Kyle, tell us about your experience of, hopefully you're set up by now.
Yeah, so from an encounter specific perspective, I wouldn't expect any like documents without data, right? There are scenarios where we intentionally flag saying we don't know they have data, right? Like they have no known allergies, that stuff. We're not saying those are considered empty sections, right? Like those are
No, those are
structured.
not.
So
Right.
you can get documents that have appropriately flagged, they do not have this information, but it'd be unexpected to get a document where all sections are simply blank with no data at all. So the CCD is similar to Epics, right? Like it's a quote unquote more of a living thing, right? Like as you're moving through, the data gets updated each time you generate it, it would expand. So you might have cases where transitionally the section doesn't have something, but the next time the document is generated, that data would have, been flagged as being relevant.
Okay. Great. Thanks, Kyle. Yeah, and so I guess Teresa and Eden, like to me, this is kind of the setup of like, maybe, folks, it's like I'm waving my hands a little bit to say like folks may not be intending to do this. And so I think right. So like maybe the idea that we could add a rule or something, and I don't know exactly where this rule would live, that like, don't generate completely empty documents is a fair request. But I still am curious to know on the VHE side, do some more digging, like why are people doing this specifically with those vendors? Because it just, so we're like 3 folks have said like they wouldn't intentionally do that.
Right, so it can be those unintentional. Oh, go ahead, Catherine.
Yeah.
Sorry.
What I was wondering is, and I can't figure out how to raise my hand, so I'm really sorry. Do you think that those are ADT encounters that are coming over? Since the volume is so high and there's no clinical data, do you think that those are ADT encounters notifications that you're receiving with a C-CDA wrapper? I'm just wondering.
These specific that we looked at were not, but that is a great point for other use cases to look into and a great call out, right? It could, in others case scenarios could be, but that's exactly why we brought it, right? These are, no one's intending. I work on the clinical data quality team and no one intends to send bad data, right? So it's all, that's why we want to raise awareness to this topic and maybe propose some ideas to have this happen less frequently, because I'm sure we're not the only organization that accidentally stumbles across this, right? And so that's, wanted to gain everyone's thoughts. And Brett, you're doing a great job facilitating this. Are these ideas we're proposing here on this slide, reasonable? Can it maybe help keep those unintentional items that come across with no clinical data happening? And then, similar to progress note, I know we'll get to that in a moment, but having those notes at least be a required option in addition to what's already required. Are these, reasonable topics? I'd love to hear thoughts. I know we have a few hands up.
Yeah, go ahead, Ryan.
I just wanted to mention some of our customer organizations have seen a variation of this issue in the past. I was able to find a documented version of it from last year, and it sounds like what they were seeing is a high volume of CDA documents that have really exactly what you're saying, no content in any of the sections, but include a message such as the patient has been admitted. And so I personally have not seen one of these documents myself yet, trying to get an example of it, but to me that sounds almost like a event notification type workflow, and potentially maybe, you know, it's being embedded into a CDA document for the payload of that message.
Yeah,
We've heard that complaint in Texas, Ryan. That's why I brought that up with the with our community stakeholders. We've also heard that there are EHR vendors that send a wrapped PDF in this way so that there's nothing but the header, and then there's the discharge summary, consult, and H&Ps that way.
Do you think these proposals on the screen here would help those situations, you know, that you're experiencing?
I think so, but and I'm going to
want to think, but
take them back to the stakeholders and ask them, but I think so.
I think so too. Well, I guess I kind of wonder if maybe with that example, there's maybe use cases where CDAs are being used today where maybe it's not really relevant or the right tool to use.
Right.
I would worry a little bit about having too strict of conformance statements, and like then sort of blocking out real like workflow use cases. But I, you know, I would be interested to understand more like how and why these documents were generated in the first place, that leads to essentially no content in them.
Yeah, then I see Lisa's hand going up. I just have a quick, like, I think sometimes even having these, like, documenting these rules and guidance somewhere, like where it is that you can point to say, hey, you know, why are you doing this? This wasn't the intended thing, could help generate discussion and maybe adjust how they're doing that event notification or whatever they are doing. But go ahead, Lisa, I know your hand's up.
Thanks, Brett. I wanted to mention that I think another place to dig around in as you sleuth this out is around on-demand document generation and the way the queries are being asked for. The new data usability guide has a section about using proper codes. And one of the first places to start with proper codes is at the top, properly coded documents, so that we could ask for documents that are the kind of documents we're really looking for, and not just do some general on-demand thing, which might cause ADT information that's available in the database to get coughed up as a document because it could be made as a document. And people are asking too generally for, do you have any documents about this person? And I think it's a combination. All of your requirements seem very reasonable to me, but I think at the same time, we need to look a little bit at maybe a new thing like smart queriers, not just smart senders and resilient receivers, but smart queriers and what they need to be doing.
Great. Thank you, Lisa.
Yeah, I think the whole refinement of it all is great, right? The idea of even talking about it is great, but there needs to be more analyzation about the why, and then possibly working through a smaller case scenario that gets you the higher quality documents that you want. And then you can suggest best practices versus enforcing shall nots and harder rules at the global level.
That's Rachel. I have a okay, sorry, I can't raise my hand. I'm on my phone and I can't find the button. But I have a comment regarding why I know this is happening. A lot of EHRs, especially the smaller EHRs, have a only way to get data out of their system is a CCD, and they need to notify someone else that a patient is there and active, and they're triggering what's called a preliminary CCD with very little data in it. That registers the patient in whatever ancillary systems available for them to register, and whether it's internal or external. and that's their mode. They're not using ADTs, not using SIUs because they have problems with those, with cancellations. They have problems with patients being transferred and the information not being received by the outside system. Not saying this is a good thing, but I just wanted to shed some light on why it could be happening.
Yep, that's great insight.
Yeah.
Thank you, Rachel.
And I see Matt Davis couldn't raise his hand. Did you want to come off mute?
No, so anybody who wants to raise their hand, click on the reactions icon, and then the raise hand is there. We just couldn't find it.
I did. Mine's not there.
Yeah.
Oh, there it is above it. Thank you,
Yeah,
Matt.
no problem at all.
Appreciate it.
Got you covered. I couldn't find it either.
Okay.
No, but this is a great topic. I know we have 1 minute left. I was just curious. Y'all mentioned that the date of death isn't really helpful information. Can we maybe expand on that a little bit of why that wouldn't be?
So it's helpful information, but we would still hold it to that desiring more clinical sections, at least in there, right? Was there an encounter? Was there an admission? Was there something more, right? The header just saying patient date of death yesterday isn't enough for the clinician to still, update their chart on the receiving end or make a phone call to a parent, right? Or a family member. So still just wanting to hold it accountable. It still matters, but it's just would hold it accountable to that number one on the screen there.
Yes, that makes sense. Thank you.
I think as far as advice goes, as far as when y'all set this advice and y'all put the recommendations out there, if an internal system or system decides between each other to share the data that way, that's one thing. But for it to go out to an HIE or to as a transition of care or any other type of direct message out, that makes no sense, right? Because you don't have clinically relevant data. But to say that you shouldn't create CCDs like this, I think it's more about sharing, and you really shouldn't be transmitting CCDs without the data that's needed in it. Because some will trigger it with just vital signs to say that a patient was triaged, and yeah, that's relevant data, but is it really enough to make a clinical decision? Probably not. Right.
We have 2 minutes left, and I do want to I don't mean to drop a thought and then run away, but I do want to continue about the progress note requirement suggestion they had that the VCs come up about minimums. The progress note, I think we wrote, I don't know, 2009 or 10 is my memory when we first created it. Before we had this idea of kind of a clinical notes section. And I think the suggestion that we require, we require a clinical notes section to include the actual text of a progress note seems like a reasonable thing to consider. And I'm curious if folks have any quick reactions about increasing the requirements on progress note to require the notes section and note activity entry.
I don't know if Ryan wants to speak up, but I remember when I left Epic that we were using the assessment and plan section as the progress notes section. So I would think requiring the entry there would make some sense. Otherwise, if it changes, then I think that approach would need to change. But I don't know if you still do that, Ryan, or not.
Yeah. And I guess my thought too, in addition to that, is I don't know, among all of the encounter types that are, possible to document, I'm just not sure if everyone is always going to have a typical progress note, like a standard office visit might, even though those encounters might have other documentations done as part of them, like maybe there were orders and procedures and results, but maybe there wasn't a standard progress note, and that's just the nature of that type of encounter. So that's the one thing that I would kind of worry about is.
And Brett, Ryan, that's a great point. It's something we've thought about. I think it brings back to Lisa's point of making sure you're coding to the right document type. Because of course there's a discharge summary. What we're seeing a lot is that and it's great discussion in the chat too. Thanks so much, everyone. But what we're seeing a lot is, they're using they as in broad term nationwide, cross variety of people are using progress note template as kind of a catch-all, right? Okay, let's just use this one. But I think something Dee Dee Davis, you may be able to chime in on too, is using the right template for the right encounter or right visit or right, use case is also critical moving forward.
This is Jim Gray. If I can just
We're
add
at,
one
we're
thing.
at,
Oh, go ahead.
sorry, we're just at time here. So is this the proposal you've got here? Is it like, what's our action items from this? And do we want to come back to this tomorrow maybe, or Brett and others?
I'm gonna leave that to Brett. We just appreciate
Yeah.
time. We're happy to bring this to other discussions and other groups. If you find, today and tomorrow may not have enough time, we're happy to bring it to other HL7 meetings or anything that you may have. The discussion doesn't need to end today.
Yeah, I guess, John, I see kind of two potential follow-ups, and there probably are more. The first is, I think, on the kind of the generation of empty documents. If we were in a room, I'd look at Dee Dee Davis and say, like, Dee Dee, I think this is probably a pretty good data usability work group topic. I know you have a big list there, but like, I think that's kind of where those general guidelines could fall. And so if you're open to receiving that, I think Teresa and Eden, I mean, I'm obviously happy to join you too. I think that may be a good spot for that. I'll pause.
Absolutely. The comment period is open for data usability. Please let us know how we should if the more descriptive wording that we can add, suggestions during the comment period, please submit those, because I'm more than happy to entertain that. But it would have to be something that, we get consensus on. So I can't guarantee that we'll include it. We need to make sure that the work group as a whole reaches consensus that it's valuable, but please send it during comment and we'll make sure we tee it up, because I know this has been a long-standing concern for the VA, because I've been working with your team, Teresa, and company for quite a while. So anything I can do to help.
Yeah, appreciate it. We'll definitely comment, and I can email you and we can coordinate on this slide deck as well if you need.
Absolutely. Sounds perfect. Thank you.
Dee Dee, in terms of commenting on that, do you mind either, just for the minutes, make sure, can you put that in chat for other folks who aren't as plugged into what the data user work group is?
I
and like
will.
what that means?
I will. It's going to be in my slides tomorrow as well, but I'll put it in there today, right now.
Okay. All right. Great. And then the other, Sean, sorry, I know I'm taking 2 more minutes here, is I'm happy to submit a comment. I mean, Teresa and Eden, it's not uncommon to say, like, hey, let's put a ballot comment against the progress note template formally at HL7 to generate discussion about requiring the note section. Like, I don't have a strong, I think Brian made a good comment about not always being there, but sometimes having a formal response of like, here's why we didn't do that, may be helpful for the future. And so I think let's just submit a JIRA tracker against the spec and get some feedback there.
Yeah, just put it out there, right?
Yep.
Thanks.
All right.
Thanks, everyone.
Thank you, everyone.
All right. So next on the agenda is Catherine talking about interoperability for lab data.
And I will try to catch us up a little bit, but I think that this topic is going to be equally exciting or have equal opinions on it. So we're going to talk about laboratory data. And I told you that part of my role with Texas Health Services Authority is to work with the stakeholders in our community, our clinicians, on what they're frustrated with. And they're frustrated. And we have a work group called Standardizing C-CDA. As you know, we presented last year or maybe the year before on standardizing the content in the discharge summary C-CDA. So part of what we're going to talk about today are the laboratory results received via C-CDA and LUNC code assignment and the frustrations with both of them. We don't have answers. We want to come to you guys to see what answers you might have. So the problem is clinicians get inconsistent laboratory results, particularly when they're being transferred in from other organizations. Say a small rural hospital transfers into an academic medical center and the laboratory information comes across just in the date it was resulted, or it comes across as a PDF attached in the C-CDA, or worse even yet, it comes out as a stack of papers that the MS driver hands the emergency room physician. Not the best use of time for an emergency room physician in a critical situation. just not what they really want. So what we really want is that laboratory tests should be organized by the test and grouped together. And the reason is for efficiency and for patient safety. So this is an example of what it looks like. How hard would it be for you as an emergency room physician or a clinician caring for a critical patient if this is the C-CDA that you have? You've got 5 different tests displayed in the order in which they were resulted. Here are your chemistries, glucose, sodium, total protein. Then all of a sudden you get some urinalysis information in there. You go, what? What's going on here? And then you get some hematology information. Then you bounce back to chemistry. Now, would you trust those results? Would you put somebody's life in your hands working on helping them with these results? No, you wouldn't. What you would do is you would stop and you would say, call that hospital, have them fax me those laboratory results. Call that clinic, have them fax me the laboratory results. Because you'd be frightened that you were going to hurt someone. So that's what we're dealing with. Our clinicians here in the state of Texas are telling me that it's inconsistent based on EHR vendor and based on provider. And they want to see the results in a consistent, standardized way. Here's another example that my friend Andrea Pitkus that I met on the Sequoia Project Data Usability Project. Brilliant woman. What she told me about was laboratory order name indicates that it's an ACTH stimulation. However, the lab test result name is cortical. So, and this is an adrenal insufficiency. And when I looked it up and what Andrea sent to me, it said the clinician should go ahead and start treatment if they think that this is the issue. But what if they get the result back? Don't you think that they deserve, if they are to get the results in a C-CDA, that all of the information would be together so they don't reorder this expensive laboratory test and so that they can be sure that they're treating people the right way? So these are bad examples of things. This is what our clinicians want to see. They want to see that when they get a lab test in a C-CDA in the encounter, that it is grouped in the very same way that it would be grouped within their setting in the appropriate group. The laboratory results should be grouped by test. And you can see why that would be important, so that they can trust the results. And we are big members and participants in the Sequoia Project Data Usability, and in their implementation guide version 1 that was produced December of 2022. My friends from California grouped each and every one of these results: blood chemistry, urine chemistry, coagulation, endocrinology, hematology. They grouped them together. They didn't group them alphabetically, did they? Now, there's a reason these clinicians group them together, because that's how their mind thinks. The results go together. So what I want to talk to you guys about today is, what can we do to improve the result organizer template to resolve this issue? Is it possible to change the human readable order without changing the result? I don't know. Who is responsible for the human readable information in the C-CDA? The content creator and the content consumer. I can tell you that there are varying levels of EHRs in the Texas community, and I bet it's the same in all other communities. And we have to work to the lowest common denominator. So we have to make sure that that patients are treated the same regardless of the EHR vendor. So that's the discussion that I want to kind of have with you guys, and to hear your thoughts. What do you think? And I can't see anything, so somebody else is going to have to call out if somebody raises their hands or has any thoughts.
I think it's a very reasonable request. I think You know, the idea of at least approaching it is definitely worthy, especially if you're going to focus on human readable and find a way to make that work. That still does require coordination, but I still like the minimal approach to get a improved result.
Thank you, Matt. Ricky?
I gotta find my mute button first. I put in the chat too, but is there a way that all clinicians want to see lab results? Because if we have agreement from clinicians on how they want to see lab results, then we can figure out what those what that entails for the EHR. And once we know across the different EHR systems what the requirements are, then from an HL7 perspective, we can figure out what format we need to produce so that they can do it. Or, you know, that would possibly entail, you know, an HL7 spec around the functional requirements for the EHR, because oftentimes, or at least on the V2 world, which is, you know, what lab still lives in, the specifications really are about how the data is exchanged, not how the data is displayed to the physician after it's consumed by the receiver. So I think there's a little bit of disconnect between what is being sent and received and what is being displayed to the physicians. And I wholeheartedly agree with you. It's a mess. So.
Well, I think, Ricky, we do know how clinicians want to see it, because at least in the state of Texas, and it's hard for me to believe it's anywhere else, they want to see it in the same manner as if they were treating someone within their EHR. And all the EHRs display the laboratory results created within their organization as the data source in a consistent manner. So I think we have that handled. And Lisa? Lisa Nelson
also has trouble finding the
Sorry,
mute
there we go. Sorry.
It
Some people can argue that this should be handled by the content consumer. They say, ingest the document, read all the entries, and then sort it out for yourself. You know, make sense of it for yourself. But that's not really living to the intention of CDA documents, where human readability is one of the core 6 requirements for making a good document. And so there really is a responsibility on the content creator side to sort out and design the human readable to meet the requirements of the reader. And I think that in this case, you know, we don't have to necessarily argue about how their machine entries need to be formulated, as long as the entries are linked to the narrative and the narrative is sorted out the way the humans make sense of the information. I think it could be, you could standardize the human readable without putting undue restrictions on what the content creators do in terms of generating their machine readable entries.
Yeah, agreed.
Thank you, Lisa. John?
Yeah, I have a lot of firsthand experience with this problem. I actually published a little bit on our medications back in a 2018-2019 paper, that just the same, even in certification process, the same 3 medications were represented wildly different in different EHRs for the human readable aspect of it. I think that what you said, Catherine, is correct, that people want to have a consistent view, and generally they want that consistent view that's aligned with how their EHR displays the information. However, not all the EHRs display the information the same way, so that even though it's consistent within an organization, it's not consistent across organizations. Some people want to see reverse chronological, some people like alphabetical, some people like other orders for all these types of things. For everything I've seen has been that when you give people choices, they generally don't all choose the same thing, even though you might have a default that's more common for some of this. The way that I approached this in past lives was that we would have to take like results sections from 5 different EHRs and their C-CDAs. there was no way that we could jam together a narrative, 5 different narrative sections in a way that was consistent, because all of them had different fields and different orders and different sorts and different column headings, all that type of stuff. So we went back to taking the machine readable content from each one of those, because that is where the standard really applies, and then regenerating the view that our customer wanted at that time for it. So I don't know if that helps or that makes sense for it, but I think that I don't think that you'll get to I mean, I hear you, Lisa, on like, yeah, human readability is like a desired attribute of CDA for it, but it's not that people are producing bad things, they're just producing different things than what the receivers want for it. So I think it's something that we're going to have trouble saying the sender has to absorb this responsibility. I think the receiver, if they want to regenerate narrative and have it consistent, they should parse the contents like you kind of said.
But John, what happens when it's when the EHR vendor cannot do it, and then it comes out looking like this, where the laboratory data is all scattered about? Then you really do move back to faxing.
Well, I mean, I agree that it's not good, but I mean, the solution to this, if you want to do it right, from my perspective, you got to parse the contents. You can't just say we're just gonna, like, I mean, I've designed this a little bit for one of the things in a prior IAT, which is, right, let's reorder the sections. That is totally doable from a narrative perspective. Like, we're going to move the, advanced directive section first for this use case, or these other ones first for these other use cases. Lisa's done a lot about how to create SOAP notes, kind of the SOAP, subjective objective assessment plan, kind of ordering of documents for it. That's totally doable, because the sections are standard ways to reference that. Section text is pretty standard for it. But once you get within the text, there is no standard. So it's just like, this is a pretty daunting, I think, and insurmountable task to say that we're going to standardize the text at this late juncture for CDA.
John, those some EHR vendors do standardize how the laboratory results appear in their C-CDAs. Athena does and Epic does. They're very consistent. So that's why technically I know it can happen. And do I know if it's hard or not? No, I don't know. I just know that clinicians in Texas prefer the C-CDAs from Athena and Epic, because of the laboratory results are organized in a consistent, standardized way.
And I think that would be a great thing to like publish and then take that back to the other EHRs and then just nudge them to try and present their labs that way, because it's a better thing for it. But I think that if you have a C-CDA that's not the way you want it, I don't think that there's going to be an easy way to move around text within the section text within the kind of human display to reorder it the way you want. I think you got to go back to a kind of source.
I think though a great part is if you do allow sorting of a table of that particular data. And that's possible, what you said about the content consumer being customized, whether it's 5 different ways they want it, they have control of those 5 different ways, at least by sorting of the columns. But that's if it's an option. I think there's ways to move forward that are open, that aren't limiting, that shouldn't be too much of a lift if you work within the confines of, let's say, a table. But outside of that, that's where my kind of opinion and feedback ends.
Yeah.
Thank you, Matt. Brett, you had something.
Yeah, Catherine, I think I appreciate you saying you have a couple of EHRs that do it well. And I don't know, when you hear John's answer, I really appreciate John's answer about like John was a sophisticated product who could take the 5 things and aggregate it and do cool things. And like, I suspect you're in a spot where you're like,
no, that's not the life I'm living, Brett. I'm responsible for the HIE in Texas, which
you get what you get. And
yeah,
so,
that's right. I get what now some of the stakeholders are very sophisticated, but the majority are not. So I'm worried about the lives of those Texans being taken care of by those unsophisticated EHRs.
Sure. So in that laboratory work group that was run under Sequoia, Did you ever get to a spot where you could say like, this is a target view, like a, you know, a best practice recommended view that you could point to? Because I think John's comment about like publishing something that you could point the vendors to say like, here's the best practices. It's not gonna solve everything, but it's like, it takes you a step down the journey.
Well, thank you. And I appreciate all of your comments on that. And we didn't quite get there, but we sure might get there. I think everyone recognizes that it's a wrinkle. All right. And
well, and I guess, oh, sorry.
Go ahead.
I think sometimes folks can get hung up in standards about like, everybody hasn't agreed to this way, or there isn't a universal clinical view. And I would say like, that's, you're not gonna get there. So like, just publish like the best you got, point to it, and if folks get there, then you can raise it again.
Yeah, that's a good idea. And thank you, John. That's a great idea to publish. All right, so they have another issue, and so I'm going to try to go through this. It's LOINC code assignment. We really want to be able to trend laboratory results that we receive from other organizations. Just like John said, we want to be able to incorporate them and infuse them into the EHR so that you can look at the values across time. However, there's a wrinkle with that, and that's LOINC code assignments. And when I began to try to figure out how are people assigning LOINC codes in their EHRs right now? Well, some organizations assign it based on the reference material from the manufacturer. So they just enter whatever the manufacturer says. Some people, the pathologist assigns the LOINC code. Some people, the laboratory LIS team assigns it. And some people outsource their laboratory work to LabCorp Request, and they just take whatever LabCorp Request says. So, and then some people, when there isn't anything, there's no local code, so they don't assign anything at all. So it was a very, very different based on who I talked to across the state of Texas. And even some of these were rather large organizations. So in order to trend those laboratory results, we got to figure out how to accurately and consistently assign those LOINC codes so that it's not a big mess. All right. And yes, Ricky? Ricky?
That's what the LIVID standard was designed for, so that the IVD vendors who know their test best can provide one or more LOINC codes that are appropriate depending on the clinical context. And then that's what should be used, but it's not implemented and used across the board. So you're absolutely right. How to assign a LOINC code is problematic.
Yeah. So, and here I got this from, if they don't have a LOINC code, then you send a placeholder code. So it's just very, very difficult. So the LOINC code, in the more research I did, the LOINC code is specific to the test and methodology. Manual review of the test and methodology is important, but it's tedious. And that's why you really can't just take the reference material from the test, because it doesn't include the methodology, which was something I had to learn. There's inconsistencies. People interpret it different ways, and there's not a LOINC code for every test.
Correct.
Yes, Ricky?
I said correct. There is not a LOINC code for every test.
I know. So it just kept getting deeper and deeper. And so my friend Lisa Nelson, who I was talking to about this, said, well, let's talk about this at HL7 and what can we do to improve this process? Is this something that artificial intelligence should be able to do? And Ricky, what you were talking about, LIVID, L-I-V-I-D?
Yes, L-I-V-D.
LIVD?
It's the LOINC to IVD mapping standard that actually the IVD industry produced or came out with, and then HL7 is producing the JSON format for it. There's an FHIR IG that should have been published a while ago. I don't know what's hanging it up specifically other than resourcing. But some vendors produce that and share that with their customers already. CDC has some livid files for some of the infectious diseases that are available for tests that are purchased, right? So lab developed tests are a whole nother ball game because that may not be publicly available somewhere. So in that case, the lab that is developing that test would have to ensure that the proper line code is assigned to it.
Sarah?
Sarah? Oh, I'm sorry. Jean,
It's
did
all
you
right.
want?
No, I was helping you with the hands.
Okay.
Yeah, it's hard to see whose hand is raised when you're displaying your screen.
It is.
I don't have any answers, but I'll just highlight that the ONC, or now ASTP, about 2 years ago now, Congress asked us to write a report on the use of data standards in laboratory ordering and resulting, and a lot of the struggles that you just very succinctly described are now summarized in that report that's going to be published this fall. And Ricky helped us write that report, as did Andrea Pickus, who you said you spoke with, and just acknowledging that it's a complicated problem. We do discuss in the report the livid specification and how that could support better, not just broader use of link codes, but more accurate use of link codes. It needs to, the application for link codes needs to be robustly applied, but also accurately applied. Also acknowledging the burden of who's doing the code mapping. We discussed that and how we might look at that from a federal perspective, and we did partner with our federal friends, FDA and CDC and CMS, to get their thoughts as well, to add to our possible menu of things that we could do, that the federal side could partner with SDOs and the private side of the community to work on this link code and SNOMED code, and just terminology and general application for laboratory ordering and resulting that makes it not so burdensome and more accurate.
Thank you, Sarah. Gay?
Yeah, so I just wanted to make a comment. I spent a few years working at IMO and with respect to link codes and the challenges, even when there's like many people looking at people's local lab codes or implementations, lab codes, and there are always a number of them that are one of these. You know, use one of these because they're just, the local codes are just not mappable, and it's not necessarily that. It's not always that LOINC is wrong. It's that some of the local codes are, you know, pretty different and not necessarily something that you'd want standardized. So there's that side of it as well that I think that you have to consider when, especially if you're talking about AI. If many people looking at a set of codes that are very familiar with LOINC and still have to assign some of them to, well, your local code could be one of these 5. You know, you need more information.
Wouldn't it be wonderful if ONC, that I now have the name wrong, had a database where you could run through there and it would automatically assign the LOINC codes for you and you could just load it into your EHR? That way we could be consistent. Isn't that Sarah? I hope you think that's a great idea.
That's what the SHIELD group is trying to do with LEADER, so the Laboratory Data Interoperability Repository. So it's taking the LIVIT content and providing all the coding required for each of the lab tests. So we're trying, we're working on it, but it takes a little bit. Yes.
Oh, Ricky, I'm just going to hug you virtually.
So
all right.
What do we have for an action? I think from the first topic, there was raising some ballot comments. Is this the same here? Getting I see some things on like result organizer, maybe you know, providing some more guidance on result organizer, grouping, you know, the lab tests of, you know, to your first item, grouping lab tests of the same kind together. So all your analysis tests go in one and all your hematology go in another and all your blood, you know, as opposed to random. And then the second one on LOINC codes coming up with, I know in FHIR, the vital signs, you know, has sort of picked LOINC codes, and US Core, I think, may have done something like that. Is that something where we want to do the same kind of thing here, where you sort of say, these are the LOINC codes that apply to these kinds of lab tests and bless certain LOINC codes for that? I don't know. I mean, we don't have an answer to that, but maybe I think the right follow-up for this is that some ballot comments are made against C-CDA now that we're able to make changes, right?
Mm-hmm.
Okay. So we'll expect to see some ballot comments around lab test codes and result organizer orders.
And Jean, I see something from Ricky here.
Yeah,
And
I put the
maybe-
link to the SHIELD roadmap, strategic roadmap in there that describes what LEADER is. It's one of the aspects that SHIELD is working on. And then I was also going to put in the link to the web page that has CDC's livid file collection. So there is the file for SARS-CoV-2, HIV, Lyme, and then some of the vendors who publish their livid files broadly, so not just to customers. The links to their livid files are also there. So I'll put that in the chat as well.
Thank you.
All right.
Well,
we're running a little bit behind, but that's okay. We'll just take it out of the lunch break. So next topic, Gay and Brett are going to talk to us about the USCDI 5 updates.
Yeah, I think Brett's going to take the
Thanks,
screen.
John. Thank you, everyone. Cruising along. This has been a great start. I'm loving the discussion. Thank you, Catherine, for bringing the lab stuff forward. I think we could probably spend another hour on it. So the setup for this, I want to make sure everyone can find the design work for USCDI, V5, and CDA. So it's a project underneath structured documents. So I'm on the 807 Confluence page. Underneath structured documents, we have a project section, and it's a C-CDA project. And the focus this year is on the C-CDA R4 ballot, January 2025, and the USCDI V5 guidance here. So the first part, just to make sure everyone's had time to just confirm, now that I'm presenting, I'm thinking, folks, let me make sure you see my screen. Yep, looks like it's good.
Yep.
Okay, so just a quick check for folks who haven't, looked at the latest USCDI V5 published by ASTP ONC. They did make some changes in response to our feedback of removing not just our feedback, but of course the broader community feedback. They removed the test kit unique identifier, and they, based on the feedback of level of capture at labs and exchange, low maturity, and then on orders, I think we had several discussions at the work group meeting in May about orders as like data class itself is quite broad. Could include bed changing orders, nutrition orders, a whole set, and trying to understand exactly what the policy objective was. And they split that out to be very clear. These medication lab, diagnostic, clinical tests, and procedure order is the priority for now, and then we can grow to others in the future. So I think that's a very helpful clarification for us. And then just added some additional text to route administration. So those are there. And then the formal, obviously, and the ONC USCDI design website. If you're like me, you like to go to the source. So, the way you get these is a little slow here. Hopefully this picks up here. So USCDI V5 tab to see the web view, but then you can download the PDF. And then if you want to see the differential, which is what this is showing, the things that are new, you can get that inside the standards bulletin. That's kind of the sweet spot. That's the first thing I think myself, Gay, Eric, Haas, others who are doing design for USCDI, we immediately look to this because it describes the new pieces to USCDI. Okay, so in terms of timelines here, we're here today, it's the 7th, and we're going to start meeting weekly. We're canceling next week, but then after that, we'll meet at the second hour of structured documents and kind of preparation to the work group meeting to work through the designs. The way we've done this in the past, and we made changes, I think, with the dogwood team being on deck to put changes into the continuous build. I haven't quite, in the past we had done everything on Confluence and then migrated. I don't know if we've quite settled in, we'll see if that's the current plan, but I think there's potential for us to start putting some of the things in the continuous build earlier as we go, but we'll see. So that's where we're at. In terms of today, there was a lot of chatter about advanced directives prior to the call, so we'll spend a little bit of time on that today. But I think the first thing we're going to spend a little time is interpreter needed. And so ONC has put this underneath the demographics piece, and it's just simply an indication of whether a person needs language or interpretation services. For folks who have not seen the CDA model, there is a spot for kind of language communication today. And in there, there's kind of a proficiency level and preference indicator. There isn't a flag that says, yes, no, this person has interpreter needed. So it doesn't quite fit the existing CDA model. And so we've been kicking around a few ways to handle that. Gabe, do you want to talk about what you learned on the FHIR side of the house?
Sure. So this is actually both, we always are considering what's going on in FHIR and what's going on in C-CDA. And I had a discussion with Sarah Gaunt, who's been doing healthcare associated infections CDA guides for many, many years. And they have a recent requirement, a newer requirement for also not only interpreter needed, but also was interpreter present. So we don't have that latter part as a requirement in USCDI, but we do have the interpreter needed. And we had some so their design, and she specifically says don't use this, is to leverage the negation indicator, which I am not sure if you're in the CDA world, you may or may not know, hopefully you do know about the use of negation indicator and how we've used it in the past and kind of sort of how we're moving away from it a little bit. So I guess, if there's folks that need Brett and I to explain or show what negation indicator is, let us know if you want to see that. Okay, I'm not seeing anything, so I'm assuming that everyone knows what negation indicator is.
No, I was just going to show a design for a second here. So this was this was a design. Sorry,
so you want me to speak to the design?
Yeah, you can walk through it. Fine.
Sure. So there's a negation indicator that kind of sits at the top of entries, and you don't have to use it, but you can. It's sort of like saying yes, no at the top. So if you have something that says, see where it says down at the bottom at the value binding, it says has a link code interpreter needed, and what they do is they set the negation indicator at the top that says true or false. So if you have, and here it's not here it says you should have a negation indicator. You shall have a negation indicator, but it doesn't say what it is, because if you set it to true, that means yes, an interpreter is needed. But if you set it to false, which is there's only two options, then it means no, interpreter is not needed, and there's no change in the code.
Other way around, I think.
Other way around.
Yeah, negation indicator false.
Right, that's right.
Do need
That's what's confusing about it sometimes.
Way to demonstrate, Gabe.
Yeah, see, I did that on purpose.
Wouldn't it be better? I mean, I just shudder when I see assertions as our observations. Like, wouldn't it be better that the LOINC code of interpreter needed as the code, and then the value can be a Boolean?
Yep, that would be better. And in fact, Sarah said she suggests don't use this design. But I did want to be sure people were aware of it and to get people's thoughts, because that I think is what we are going for, at least something like that. Because in addition to just having yes, no at interpreter needed at observation code, and then yes, no at observation value, there's also a LOINC answer list that has yes, no, unknown, and something else, I think, with maps to SNOMED qualifier codes.
Right. Al's got his hand up.
Al's got his hand up, yeah.
Yeah.
Hey, does this model mean the same thing as whether the flag is true or false? Does it mean the same thing as asserted or not asserted? Or because that's kind of, I think that's really what we're trying to get to, is whether or not somebody asserted either by themselves or on behalf of someone else that the interpreter was needed.
Yeah, you don't need the assertion code to say that if you're concerned about us removing that, because it's an observation. It's still going to be, in fact, a little bit more direct observation, because you're not relying on negation indicator, which some recipients might by accident ignore. So
Right.
it actually is a more straightforward design to have that code that currently is here in observation value up in observation code, with then the answer. It's more like the question, and then the answer is, yes or no, or yeah, thank you. I was going to say maybe we should bring that up. So the associated LOINC answer list with the codes are no, yes, and unable to determine.
I see, it looks like Brian's hand went up.
Yeah, I just wanted to clarify that this goes back to a conversation we had a couple months ago, I think, but in the USCDI data element, it's I guess kind of an assumption that it's an interpreters needed to or from some language to English, like that the care they will be provided in the future is in English, so then they'll need an interpreter to English, to and from English.
Yeah, I think that was the discussion we had at the last IAT, and we've had it even in sessions at the working meetings, that that a simple flag to say yes or no, or I assert I need an interpreter, isn't enough to know. If you're Hispanic and you're going to a hospital in southern Texas where they all speak Hispanic, you don't need an interpreter because they're going to talk to you directly. But I think the USCDI flag is there, and so we need to be able to handle that. So I think they'll have creating something like this, an observation for this flag, but also recognizing that there's language communication, which allows you to be way more specific in CDA about what languages do you speak. So hey, I need an interpreter and I only speak Armenian and Russian, and that's it. So you got to find someone like that.
Yeah. So I think Gabe brought, thanks, Sean. And I do want to do a few things here. First, I just want to, I think, I see a question in chat about which HIG. I don't think it's actually published yet, Lisa.
Correct.
And so, but I just want to, put a stake in the ground of we've learned our lessons on negation, that it's just too tricky. And so, unless someone makes a big stink, our plan is to not use a negation indicator to design to do this. So we would use an assertion, sorry, not an assertion pattern. We would use a LOINC question answer pattern, where this LOINC code would be at the
code level. And I think that's the right way to do things. Move away from assertion observations.
So then the other piece I just want to call out, I think some folks have heard us say this, but we always have leaned heavily on the cross group projects with Eric Hawes kind of leading the initial US core design to kind of, we say, set the tracks, and C-CDA is right behind. And of course, then B2 is there also. And so the current leaning, and we haven't reviewed this in CGP yet, but I want folks to be aware of it. As we're looking at doing there's already a universal extension in the FHIR specification, so it's in the extensions published. It's in the published extensions pack, and that is just simply something we would add to the US core patient, and it's just simply a Boolean of interpreter required. And so the current thinking is we would basically, and I should probably make some notes on the as I have this. Let's see if I can pull this up here. So I want to make sure we're documenting on this page, but it's always important. Reviewed the HAI design with the viewed HI design with mitigation. Is that all, and no one objected to us moving away from negation and using negation to conclude. We will proceed with an observation code 555. I'll just grab this here.
Just a comment, like, it's great we're using that extensions. And for that consistency, then do we want the answer list or do we want it just to be a Boolean in C-CDA then?
We want to use just a Boolean.
Okay.
Okay. So FHIR, the extension only allows yes and no?
Yeah, it's a Boolean, it's just a Boolean.
It's a Boolean. Okay. I guess in V2 we'd have to add a element to the PID segment, I guess.
Yeah.
Or would it be specific for the visit? What is the FHIR extension on? Is it on the patient or is it on the visit?
Patient.
On the patient.
Because as you point out, Jean, it's dependent on where you are, right? So if everybody in your hospital already speaks Spanish, then you don't need that on the patient. That's more actually on the counter, right?
Yeah, Sarah was mentioning something like that as well.
To me, it would fit more on the encounter than on the patient itself.
Yeah, I mean, this is like a
right, because it's a context issue, really.
I mean,
right?
You could be in a Spanish-speaking hospital and still, well,
if I go to a Spanish-speaking hospital, then I will need an interpreter because my Spanish is good enough to order an orange juice, but I couldn't have a medical conversation. So for me, the value would be yes if I go to a Spanish hospital, but it'd be no.
Yeah, Ricky. So there's all kinds of things here packed up in what you're suggesting, right? So the first question is then, someone in the FHIR core made a decision to put this at the patient level, and so that would be a question to lean on them why they did this.
Right.
And then there's a secondary thing after that to say, EHRs today, do you capture interpreter needed at every visit? Is that one of your intake questions? And so those are things that, I'm happy to have people push back on us to say, no, Ricky, you have data that this is captured at every visit and that this extension is wrong and we should fix those things. But it's not been my experience that.
I don't have any data, this is not my field of expertise at all. But that's just, putting my V2 management hat on, where in V2 would we put it? And should it go on the PID or the PD1, or should it really be in the PV1 or 2? Right. So.
Right.
I see a hand.
Carmela's got her hand up.
Carmela, you have a question?
You were muted. Now you're muted. There you go.
Sorry. No, my toolbar is blocking my stuff. So hi, everybody. And I understand that, you look at the data element in USCDI, but implementation for Exchange is not limited to, reading that data element in the definition and saying, oh, this is a Boolean, that's it, yes or no. Certainly if the community decides that more is necessary, like some of the discussion about, hey, are we talking about written language, spoken language, context? I think Ricky makes a really good point, and I think we can ask some patient advocates for some input on that question. Is it encounter based or is it you know, should it be at the patient? So I think there's nothing wrong with going beyond a basic Boolean. I understand it's the quickest thing, but it is, it could be an interesting discussion.
Yeah, in terms of being the quickest thing, I mean, for us, you know, Carmelo, for us, it's I don't want to say it's trivial. It's for other, it's encounter level for us or patient level. It's on the standards perspective, it's probably no additional work to put it in either place. Obviously, we need to create a new extension, so I shouldn't say it's no additional work. It's a little additional work, but it's not, you know, at the would sway us from doing it that way. It's more of just a, you know, I always reflect on the USCDI piece of, you know, ONC saw maturity enough in this to include this in USCDI, so we need to exchange it. How are people capturing this today?
Right. I was thinking more on the, does it need to be a more complex data element than just a Boolean? That's, I'm sorry, I was kind of rambling there.
Got it.
Yeah, that's what
yeah.
I heard you say too. More complex.
Yeah,
data.
so, you know, like, so what type of communication are we talking about? Are we talking about spoken communication or written communication, or
Sign language?
Sign language, absolutely. Is the patient deaf and they, you know, they need sign language?
I'm a little fuzzy. Don't we already have preferred language and some of those things in the USCDI, the language which the person?
Well, preferred language doesn't necessarily mean that you need an interpreter. So what
No,
if
no, but I understand that, but I was saying, like, you were starting to lean into the additional things around it, and I think we do have some guidance on preferred language, which I
Yeah, so
understand.
and language should be on the patient, because that's, you know, the list of languages that they can speak or read or whatever. But then whether or not an interpreter is needed, that has context.
Right. Right.
Well, there's some additional context. There's some additional context around preferred language as well, because it's not, although it might, some people might want it to be, I certainly would, preferred language. There's preferred healthcare language, right? And then there's preferred language, and the spoken in the home is not the same thing as how I want my doctor to talk to me. So that also doesn't have, there's some potential context to be added to even preferred language. If we don't, and that has not been, you know, we haven't, there's been people that suggested that we do additional work on that, but we haven't. So we don't necessarily need to. Certainly, your point, Carmela, about, you know, there's some context missing, and there's an opportunity to add context to it.
Yeah, I think there's another issue also with, does this mean, so if translator needed is yes or no, does that mean that the organization has to provide it, or just that you need to make sure that maybe they bring their kid who speaks better English and can translate, right? So that's another question. Who's providing the translator? If we know one is needed, do we need to capture that? Yes or no? I don't know.
Well, I mean, I think we do have to consider, like, you know, that, so this extension exists in the package that standards people created. And is it used at all by vendors today? So, you know, that if it's not, that has one set of implications. And if it is, then it has another set of implications.
Agreed.
For starting points, right?
Yeah, it sounds like a mix of, you know, scoping it to whether we make this one decision right, you know, now, make it now, and then also just keeping in mind other considerations, like you mentioned, sign language, other ways to represent communication that already exists, and then the details of how that interpretation can be supported. I think some things may already exist to cover that, some things may not, but this particular decision seems like it's before any of those other topics.
I see Lisa's hands up.
Yeah.
Oh, thank you, Brett. I just wanted to mention the spot that you had for language communication in FHIR is really different than what the record target supports in CDA around. We do have a similar language preferred, but there's a lot more room to talk about proficiency in different languages. And so I think that whether we decide, you know, that the patient needs to have some way of sort of having in the patient record to talk about their proficiency level with different modes of communication in different languages, that kind of information could be used on an encounter by encounter basis to decide whether or not an interpreter is needed. But right now we start out at a place where CDA has some constructs that are different from what we can do in base FHIR on patient.
I just threw in chat and I butchered the spelling of proficiency, sorry. But the values in the CDA, the proficiency level code and the mode code are available in FHIR as extensions on communication. So you can put the same stuff in patient as you can in CDA. I know we haven't done that like for CDA, the USCDI yet, but I know I just did that mapping. Actually, we did it for the C-CDA to FHIR project. So just FYI.
Or you have a mapping to that already, you said, Benjamin? Are you on mute or did you drop?
Yeah, I'm in mute. Yeah, I'm on mute. I said I'll throw a link in chat.
I mean, that would be helpful to have that, so that we could just, okay, so that we know, that will help maybe inform our design and say, hey, this is fine for now. This is fine for a starting point. And, what comes out in future USCDI, we can then, act on. The one challenge, of course, is that if nobody right now is using interpreter needed extension in FHIR, they will after this. And so then there's even further incentive to not change going forward.
Yeah, I mean, we should definitely find out if people are already using it and make the switch now before,
or not, right? Yeah.
Yeah, exactly.
Yeah. And I think we seem to best get that information on the cross group calls. We have really good vendor representation there, and Argonaut. So that seems like a very pertinent question to ask when we get there, which I don't think, Brett, we have it on the schedule for CGP for till September, I think, September 15th, I think, or something like that.
Yeah, I think it's further down.
Brett, before I lower my hand, I just had one other thing. I don't remember who brought it up, but somebody said something about considering the use case. Maybe it was Ricky. And recently, Jim Grew shared a story with me about an ophthalmologist in an area where he knew, where the guy had to shut down his practice because he'd actually run into a situation where he was being required to provide interpreters that had some, I can't remember what the language was. And the burden of doing it was so expensive. Anytime a patient came in, he had to fly somebody from another place in the state to come and be the interpreter. And I just feel like sometimes, we can, just sort of put our heads down and march away on being able to make standards to do things. But sometimes there's much larger ramifications that that should make us feel worried about whether or not it's the right thing to do.
Well, that requirement's established by practice, by practice guidelines, by Joint Commission, by CMS, and that's whether or not a provider is supposed to provide. That's like so far out of the scope of this conversation. It just, the fact that the matter is, it's part of quality of care provision that's required by a lot of different entities. That's the baseline, is the requirement. Whether it's too hard for somebody to do it or not is.
Well, and let's just push time out here, Lisa. It's not the requirement of the standards element, data element, putting someone out of business. It's a broader policy requirement about making sure a patient can communicate their needs to a provider, and that provider providing that support. And I haven't heard the story from Jim Grew directly, and it's yeah. So there are other policy things around this, right? We're just we're one piece of the machinery here. Okay, I think Gay, are there other questions you have on, I feel like we've welcome to standards conversations, folks, about how this stuff gets further fleshed out. Any other questions, Gay, you want to ask on this one?
I don't think so. I think we have one direction, and then we have where we're going to start versus what might come in the future from USCDI requirements, and we do have a directive to really find out if what vendors are using right now with respect to FHIR and the FHIR extension.
Right, and I think I'm just adding that other extension on the page here. May need to consider additional detail. I think this is the same one. It is. Let me get that other one that was sent. The patient proficiency one here. Right.
In the chat. You can
Yeah, thank you. Just a second here. I gotta. All right, so back in business here, and I did put that note about patient proficiency in here too. Okay, so back up here, I think the next one we want is well, I want to validate. I want to spend a few minutes on clinical notes just so we can. I know we have a mix of folks who are very familiar with clinical notes. And our current thinking, so ONC, has expanded this to operative note and emergency department note, and just validate this group. We did have kind of a couple questions like, if we, do we, the document type, if we don't require this to be a document type, if not now, when will we do that? And I think we kind of went back and forth and said, these really feel like additional things that could be included inside the note section, note activity, rather than pushing a new document type. We don't think that was the intent. And so just want to kind of throw it out there and validate, get folks input that the idea of sticking with the note section and note activity to promote these two notes is an acceptable approach.
I think that sounds appropriate.
Okay. Great. And then I hope I'm sharing.
You are.
Are there pros and cons to each approach?
Well, that's a big question. I mean, I can give you a few kind of pros and, the current. So the document, I'm going to rewind in history a little bit here, Carmelo. Now we've had these document types for, I don't know, 15 years now. And document types, for folks who are not familiar with CDA, they're kind of detailed requirements by, we have an operative note, a procedure note, diagnostic imaging report, which has never been implemented, discharge summary, transfer summary, several more. And in terms of kind of market uptake, we haven't seen demand, or maybe, some would argue there was maybe misunderstanding in the original deployment of CDA. Others could say there wasn't demand for all these variety of kind of document, or I would even say note types. They were developed for folks who also are familiar with the history. They were developed by reviewing a transcription system, thousands and thousands of dictated notes to determine what were kind of common sections, and it kind of grew out of there. So in terms of kind of the kind of maybe the con of the gate is that, there is not strong market uptake for the CDA document operative note. And so there's strong uptake for the discharge summary document, there's strong uptake for the referral summary, there's strong uptake for CCD, and strong uptake for the progress note. And so the ability of systems to include these specific new data elements within those documents would be fairly smooth and would fit well into existing exchanges. Requiring the operative note, which includes like fluid loss, kind of requirements to split things up at a, maybe I should even just show it. I think Gabe even wrote that one a long time ago. Requiring all this kind of split into all these specific sections when they're not even captured that way introduces a lot of cost without necessarily a lot of value. So that may have been a little bit rambling, Carmel. I'm sorry I didn't prepare a table for that, but just the idea that it's pushing a new CDA document type that is not supported in the industry today.
Okay, thanks.
And maybe I will, just because I don't want you to be.
Brett, do we still have a valid value set that's maintained in the C-CDA value set updates that describe the LOINC codes that are proper operative notes? If you go to
Jay, do you know
like
that
the document template for operative note.
I'm sorry, what was the question?
If the value set that's on operative notes document template for clinical document.code, if that value set is maintained in the C-CDA value set update.
Yep. Yep. Whether there were codes added this year is, I'm not positive.
And I guess just Carmel, that maybe a little bit more to grab onto here is in the operative note, kind of this CDA document design, there's these additional required sections. So the anesthesia section, the complication section, estimated blood loss section. And what we've learned is sometimes these are all just kind of in a narrative blob, and they're not split out in CDA by these specific sections and have just because, for the reader, they're just kind of going down and dictating them, and there hasn't been perceived value in LOINC coding these and splitting them out into sections per se. And so the idea that this would be a kind of new requirement, I think gets pretty large when you say, hey, just include the operative notes, that we would then say, hey, by the way, the operative note actually means these dozen things, which I think is, greater cost than the return that would be to the provider and the patient. I don't know if that helps at all.
So I think we might, I agree that that's the design we should take, but I just wanted to point out that you should be using this one. But also, I did some recent queries of that in my own record, because I was like, I don't understand why we wouldn't be using that document. And, and what I found, and whether this is because how we led design, 10 years ago, or versus how we did it 15 years ago. But what I found is that when there was an operative note, what happens is like an encounter note is created, and the section that they have a section called, operative note, narrative and operative note discrete. And then in that section, in the discrete, there's some discrete data. And then the note section is just basically a big blob of what the clinician likely dictated somewhere else in the EHR. And even within that section, it says, hey, this may not look exactly like what the original note was that the clinician dictated. So, but I agree, that's what's current practice. And, certainly that's how we've done, responded to the USCDI requirements with respect to note.
If you think back how we built this, though, we built these based on clinicians dictating these sections in that note, right? It wasn't like we'd seen experience that there was a tagged estimated blood loss. It was kind of a thought that folks would see natural language processing and data enrichment to add the LOINC codes to these. And Anyway, this could get off the
Yeah, no,
rails.
I don't want to, I just wanted to say that, yeah, my original, I'm still kind of standing in the middle of the road of it, but but as far as the actual design, I 100% agree that we should continue with doing the note section. And it will be, I don't know if we have any CMS folks, if they're, what happens when they are requiring an operative note? Does it satisfy? Anyway, I don't mean to derail. I do want to say that that is what Brett describes is what I see in current practice, at least with respect to my record. But whether or not there's more value or less value in this way versus document is, I just don't know. Al, you have a question?
Yeah,
comment?
I just wanted to, I think, reiterate ONC's position on something that's come up every time a clinical note is discussed in USCDI, whether it's an implementer or somebody proposing a new data element. The question always comes up: do we mean a structured document? And we have reiterated both in communications with users through our feedback system or in our certification companion guides that we do not, the intent of this data class has never been to create the ability to exchange all of these data elements as structured documents.
Right.
Specifically says not to be confused with not to be confused with a structured doc is the language used in the official guidance. And that continues to be our position. The intent is to be able to exchange context-specific narrative. Period.
Right, which is exactly why I agree with the current design of doing it in the note section. I'm curious about what if you have any knowledge about what CMS requires in terms of operative notes or documents, or if they basically have the same.
I don't know if they go so far as to specify format.
Okay. All right. Thanks. Yeah. So notes it is.
Okay. Notes it is. Okay. Great. Thanks for validating. So I think we have about 15 minutes left. We could talk about provenance, but I do know there was a kind of request to talk about advanced directives a bit here. And so we're fairly fortunate in that in the US core design work so far, we have the PASSIO project out there. For folks who are familiar with PASSIO, someone help me out. Does anyone remember what PASSIO stands for?
Post-acute, it's post-acute care.
What's
Information,
the IO?
yes, information, something.
Yeah, I'll put I realize I've got to put a link here to this US core design too, because we go back and forth all the time. This is just we do a little hack MD page here. This is a format Eric has liked. It allows kind of embedding of the actual build. So the build is actually done as we go. And so the idea is we looked at the PASSIO advanced directive information IG and embedded right now. Sorry, I don't want to get hung up on the US core design, but just say the current thinking, we haven't embedded this fully, is that including it inside the observation, resource, slightly less constrained, and the thinking for CDA a bit, I think it's underneath observations. We talked about this last, is trying to actually leverage the existing advanced directive observation. We haven't gone through and done a comparison yet to make sure we have everything here. I don't know, I think, Lisa, was there anything specific you wanted to call it? I know you had generated a fairly large chain on this one.
Yeah, the one, design, this is sort of foundational design stuff that I think is really important to absorb, is that the supplemental guide for advanced directive section had previously established an organizer. The point of this information in the context of a patient summary or an encounter summary is to describe what advanced directive information is available. Existing documents that the patient has, either ones that they've documented themselves, or if they have portable medical orders that were authored by practitioners that already exist, to be able to record the documents that are available and information about where you get them, what kind they are, maybe some key verified information that comes from them. And then to be able to record observations that are documented inside the EHR during that encounter. So if after looking at what's available for a patient, somebody during a care encounter decides that this person's DNR status is to not resuscitate, and that's documented in the EHR for that visit, then that kind of an observation would go in the section. And I'm just concerned that by losing the organizer, which allows the context of the information to be, there is this document lives somewhere, it's verified by somebody, and it may have some key things that wants to be bubbled up, but it's all held within the context of the organizer for that document. If there's another document, there's a different organizer that's that, and then free-floating observations just that hang off the section are information that's in the EHR itself, that somebody, who's caring for the patient is writing down, oh, this is what we decided the patient's DNR status is based on talking with them, based on reading the documentation that they've got, et cetera. And there's no organizer notion. So how are you going to express that the information needs to be represented about this document, separate from observations that are just sort of stuff that's documented in the EHR?
Looking across the room, I know, just making sure folks are still here for sure, calling them out here. I guess I'll go in the same order as last time. So Ryan, I know Epic has done some work, or gosh, I shouldn't say has, but 15 years ago, I remember being in an Epic conversation about advanced directive exchange. How has that progressed, or is that still something that, is that something actively done, and how have you approached it?
Yeah, we do. So we do support an advanced directives section in our CDA documents, and within that section we have I think a few of the pieces of data that Lisa was describing, and then the associated metadata with those pieces of data. For example, within that section, we can have a list of the documents that are on file at the organization generating the CDA. And then along with that, we have the codes, the latest code status, and then the code status history. That's discrete things that we also add into that section. I think that's primarily, we also include healthcare agents. So all of that is sort of is what we group into our advanced directives section. It would be documents on file, the current code status and code status history, and then healthcare agents.
Thanks, Ryan. I think I'm who's next in our list here? I guess Kyle, my brother's Kyle, so I'm gonna go to you.
Yeah, I'm not totally sure what our support is. I know we have the ability to value the section if the data is available, but I can't give you specifics on what is or isn't entered.
Hey, no sweat. We'll ask you again at the worker meeting or prior. So this is your.
All right, I have a takeaway.
Fair warning.
Okay.
Richard, I hope you had a chance to scramble in the background.
Hey Brett. So I don't think we support advanced directive in our CCDS today. So that, yeah, we would have to take that up.
Okay, no problem. Okay, and then I don't want to leave anyone out. I feel like those were the three, right? I guess D-hit, I guess, I don't know, I guess Matt, we lost Matt. Rochelle, is Rochelle out there? I'm curious if D-hit sees this much in Exchange today. Well, I'll go to Aya from InterSystems. I know you have the HealthShare platform and can do all sorts of cool stuff with documents. Aya, do you have see much advanced directive exchange today? Oops, maybe we're missing, maybe you're double muted or maybe we lost you for a minute. While you're doing that, I see Lisa's hand went up.
Oh,
did it go up and down?
thanks, Brett. I did, I've been trying to think about this, and there was a time when we were looking, I think we were working on ODH, occupational data for health, and the original design came in with an organizer and a bunch of components, and we ended up redoing the organizer to be represented as an observation, which then had entry relationships to other observations. It just was a way of redoing the design. And so one of my thoughts is we could acknowledge, just like I think it was Epic that said they are getting all the right information in there, exactly what I was describing as what the use case really is. But maybe my hang up is that using this very specific word of observation is, if you're too literal about that, if you say that the data element, although it's named observation, the data element could be structured using organization structures or observation structures. Or we could rethink the way that we did the design in the PACP guide and, I'm sorry, in the advanced directive section guide, and say, instead of using an organizer for this top level thing that says there exists a document on file for this patient, we say that data, like the code that's in the organizer, becomes the code of that observation. The author becomes the author. The verifier becomes the verifier. We just move the organization structure into an observation structure and then still hang the observations that are from that document. For example, healthcare agents, they don't just, if they're not free floating, they're actually appointed through one of those documents. So they sit underneath the document where those healthcare agents are appointed. And we could just do the whole thing with observations, and the action item would be redo the structure so that we don't use organizer because it's too confusing for people or something like that.
Sure, thank you.
You could also convince me that don't take the word organize, don't take the word observation in the data element's name so literally, and then we can allow for designs that use organizer structures or observation structures to represent the information.
Yeah, and I guess Ryan didn't get super specific. Ryan, are those, you said you mentioned the advanced directive section on the more level, the detail, like code status, you mentioned, so that's actually a coded observation.
Yeah, it looks like we do both. We do use the organizer and include the statuses and observations underneath that. But to Lisa's point, I think we do currently structure the healthcare agents as standalone entries today. As standalone 0.48. So I think those are advanced directive observations. Yep.
Okay. All right. Well, clearly have some more digging to do here. And I think I'll just look, see if there's any hands up. I think, Jean, this might be a good spot to be back on time. And but I don't know, Gay or others, anything else, any other commentary on advanced directives? I mean, clearly there's a lot more work to do. I did save this page. So folks who want to watch these pages over the weeks ahead, obviously we'd love to have everyone join us on those calls, but we know we're still in summer season here and folks are in and out in August. But please join us if you can. I guess Lisa asked a question about V2. I don't know. I know Ricky and others came to hear this whole session with the V2
Yeah,
hat on.
it's definitely helpful. I mean, obviously that advanced directives is not my area of expertise by a long shot. So I'm gonna have to like look at it a little bit more and reach out to some folks with V2 that have that experience. But I think with the email exchange Lisa sent me prior to this meeting to get my brain working in this direction, I think the observation approach will work pretty well in V2 for advanced directives as well.
And Ricky, do you have in V2, if we do something like a sophisticated structure with an organizer that groups observations together, does that make it harder to represent the information in V2, or like would it be any easier if it was an observation that grouped observations? I'm just wondering, you know, because I really do feel like we could be flexible. It'd be easy to undo what's already sort of set in motion if it would be easier to do it the same way across FHIR and CDA and V2.
Yeah, I'll need to look more at the TXA segment to see what's in there. And then from a OBX perspective, right, we only have a way to group OBXs by using the OBX4. So that would just be a, like, you know, kind of tag everything with the same number or with a dot notation.
ID of some sort, yeah.
So, yeah. But I mean, and it's a string, so you could even give it a name of, you know, some sort and use the same name for everything. But
okay.
So I don't know that, you know, using an observation as a grouper versus an organizer makes a difference from that perspective.
Okay, awesome. So Brett, if it's possible to have the flexibility or in something and however you do the work to make it possible that the guidance is not so strict that it has to be an observation structure, I could show you how you can use the same codes and the same participation constructs and go between an organizer and an observation. It really shouldn't matter at all.
So Lisa, does it need to be discrete data? Like you can't send it as just a document in the OBX encoded data?
You can send the whole document in the coded data. And I have examples where you could, in addition to saying, here's the document, here's where you find it, and here's a couple of summary things like out of an advanced directive, you want to know if somebody's appointed healthcare agent that they've done that. But you can just as easily also just show the whole document. So if it's something short to easily read, or it provides greater confidence for the care providers to see the source document, like in the case of a portable medical order where they have a very specific color and layout, that it might be better to include a quick review of the 2-page PDF right along with the discrete data that tells you this is a pulse, this is where you pick it up from. So if you're worried about getting the current version, you can query and make sure you've got the current version. This is who authored it. This is the date it was finalized. And then you could see it, and if you wanted to read something more, you could right out of the source document.
And V2 certainly can support sending the whole source document. I just would have to figure out how well V2 can support all that metadata around it. But I think that's the TXA segment that I haven't checked in too much detail.
But if you don't send the whole document, Linda, you can still send in V2 the information that allows a system that receives that to turn right around and query through Carequality eHealth Exchange and ask for that document if it's something that they actually want to pull into their own document list.
All right, we're at lunchtime, so this has been a good conversation. We've had some good topics. We've got a half an hour for lunch. So if Jim or Dennis, if you guys want to start us off with an update on how the Eyecare specialty data is going.
All righty. I'm Jim Groh. I'm an optometrist, and Dennis and I work together on a number of different projects. So basically, I tend to work on as the interface between providers and understanding use cases. and Dennis is the developer, so he does all the technical aspects of it. Let me bring up our PowerPoint. We do have a PowerPoint, and I'm going to share my screen. And Dennis is going to introduce himself a little bit and then address the first two slides he's going to address. Okay. There. Are you seeing the PowerPoint slides?
Yep, we're seeing the
Okay.
last page.
Oh, might be better if we didn't start on the last page, huh?
Yeah. Hi,
There we
everyone.
go.
So
I mean, it makes your presentation shorter.
Yeah.
maybe we should start on the last page now.
Yeah.
So hi everyone. So I'm Dennis Bull. I do a lot of work with healthcare registries. I've worked on a few different EHRs. I've been in the healthcare industry for over 30 years, mainly instrumentation, interoperability. We even designed, this is way before Epic, and then we designed our own HL7V2 interface back in early 1990. Anyway, so that's for me. And so now I'll give you a little bit of an update on some things that we're working on to try and progress the specialty eye care. So when we started the project, and this is about a year ago, with John, Dogwood Consulting, and Jim and I, we were putting together, trying to come up with the first Eyecare implementation guide. And so when we started mapping the data, and for Eyecare, there's so much data. We're talking about thousands and thousands of pieces of data. We were trying to come up with a way to map that, and we were using Excel spreadsheets to try and, map the different SNOMED codes, come up with all the data, then, get user groups together to try and get like 4 or 5 EHRs to pull up this big data together. And we ended up putting an IG together, but in the process of doing it, we found that, mapping the specialty data to align with the C-CDA was a crucial task, but it also became very challenging in terms of trying to map the right code sets to try and follow, past, documents have been created, say from the IHE or from various places, to use the proper codes. And so it became very time consuming, and numerous steps, including validating the data, trying to adjust it, cross-referencing all the terminologies and all the documents available. And it was exceptionally time-consuming, especially when you're dealing with a large data set like the Eyecare clinical data. There was also inefficiencies in the, you went to any, Jim, but there's inefficiencies in trying to map those complex data. So what I moved to is more of a data dictionary driven system. So we basically there was lack of automation. There was no way manual input. There was just so many problems trying to get the data from the doctors for Eyecare and then map it into something that we could then generate into a C-CDA. So once we got past that, we started doing data dictionary. We did actually manage to implement the first unofficial Eyecare guide that John rendered using the FHIR and the GitHub repository. And this is the result of it, which includes the visual acuity, the refraction, some dry eye, some posterior segments, some of the basic things that you would want to communicate in a C-CDA. And so, now we're going to talk about some of the things that we're doing to try and get past that point to maybe come up with more clinical data. And, with USCDI version 3, and obviously with the discussions today, version 5, which is kind of, in process, how are we going to meet all the new certification requirements in HTI 1, 2, or 3, and all the different versions to be able to document everything that's recorded in an EHR must be embedded or available through a C-CDA, maybe with a supplemental or with other information. So that's the lead into Jim's section.
Okay.
Thanks.
Thank you, Dennis. So what we kind of learned from that project is when we started it, we found that, there's a physical exam section of the C-CDA, but we really didn't find very much guidance for how to use it. And we didn't find that it had been being used very much. And there were a bunch of existing specialty data templates. So we did use the Eyecare data template that was existing as a starting point. But again, very, very few examples of where any of these physical exam templates had been used. So in creating the early guide, what's important to understand is that really our work emphasized using the physical exam templates section, and we used very, very limited Eyecare. As Dennis mentioned, there's just a ton of Eyecare that's data that's out there. So I think that what we're experiencing and what the general trend is in sort of HL7's approach, HL7 out of necessity, as all of this stuff evolved, really had to look at general medicine and what works in general medicine. When we start delving into the specialties and the subspecialties, we're really dealing with a lot of different issues. And some of what we want to do today is make sure everybody's aware of those issues, because everybody's going to have to start addressing them, because the changes we go to USCDI version 3 is we now have clinical tests. So in USCDI version 1, there was basically no specialty data there. You could, you generated it with just stuff that everybody agreed everybody in medicine needed, but it had no requirements for anything that would be considered specialty data itself. And now we also have the requirement for all the imaging results and the interpretation of those results. So we're going in one jump, adding a lot of data and a lot of information that we need to path. And if we just look at these physical finding, templates that exist, I don't know who wrote them, but there's a ton of them. What we're going to be talking about today is one small section of the I narrative, and there's all these other ones that all potentially involve providers documenting physical exam results. And I think the difference is I think the two extremes that I see in CCDAs is I look at primary care physicians who the primary care physician walks in the room, he's using an EHR, but he doesn't even have a computer. He walks back out in the hall or he walks to his room and he dictates a paragraph or two, and that's his progress note, that's all that gets documented in it. You go to the other extreme in Eyecare, where there's absolutely no progress note. Every single piece of exam results is in structured fields. So we end up with tons of structured data that if it's recorded in structured data, it should stay in structured data as we transmit it it has to in order to be usable. So when we start looking at this issue of the challenges in mapping specialty data, first thing you got to understand, there's a ton of it. And then the next problem is there's so much of it, even the Eyecare EHRs don't handle all of this data very well. I talk to providers on a daily basis that say, well, I want to record this and this in a structured field, but I have to open up a text box and type it all in. And I'm not typing it in as a narrative. I'm typing it in and saying, this finding is this finding is this. Or more likely, they create custom templates, but then that template is separate for each provider or each organization. It's not consistent throughout the user base from the EHR, and there's certainly no consistency in the field when providers are creating custom templates. So then there's a huge variety in what data is collected. There's lots of different diagnostic equipment. There's lots of different ways of treating all these subspecialty methods. And there's a lot of different clinical approaches. So the variability that we have to consider is extreme. Just for one example, if you're just describing an anterior chamber angle in the eye, there's 6 common different ways, but it's like nobody does all 6. You do one, you do the 4th way, you do the 6th way, but when you start sharing it, the providers don't necessarily know how to interpret that information very well. So just one other example, there are over 800 OCT machines that are supplied by 155 different manufacturers in the world. They're not all approved in the United States, but a lot of them are. And there's no standard on how they output it. They output it in DICOM, but the way the numbers, the descriptions they use are completely different. So when we get in, looking at what's required in C-CDA when we're looking at version 3, and all of this stuff has to be mapped, there's a lot of stuff. So the other aspect that's important to talk about is in any of these, when we're co-managing surgery, when we're eye doctors are co-managing the treatment of dry eye or visual training or low vision, any of these subspecialties, there's a ton of very specific specialty data that's in structured fields that for them to co-manage it, they need all of that information. But I'll guarantee there's no primary care physician in the country that gives two hoots what the base convergences are. And in fact, most providers don't even want this information if they're not directly involved in the co-management of these subspecialty areas. So we kind of have to look at data a little bit different. And, you know, I think that what we're realizing is there's really a lot of challenges in getting in there. And, you know, I had to figure out a way to get an Olympic shot into the screen. But so, you know, we've got a lot of challenges here. So our first recommendation from our experience is that the idea of chucking everything in a C-CDA just doesn't make any sense to us with the volume of specialty data there is. So we're suggesting, and we brought this up at the last IAT, that you have sort of like this core C-CDA, kind of what people produce right now. And then the supplemental data, we create supplemental C-CDAs for the specialty data. So we kind of become sort of a 2 C-CDA system. And I think there's a lot of implications of that. There may be implications on how TEFCA works or care quality works. I don't know those, but I'm just saying that if you try to stick all of this data in a C-CDA, it becomes pretty complex. Whereas if we can, like a lot of times, some of the specialty data exists somewhere else. If you can create a C-CDA that just has the specialty data as a supplemental C-CDA, that seems to make sense to us. The other thing that we found in doing what we're doing is that just to identify with all that data that's out there, just figuring out what needs to be mapped. I mean, it's not realistic to say everything's going to get mapped. It's almost an impossibility to do that. We've got to figure out what, because the requirement is to only map what gets recorded, not all the terminology that's in existence in, you know, literature and stuff. So how do you figure out what that is? So that's not necessarily that easy a task. And we found that when in the first program, when we were using an Excel sheet, that was not an efficient way to do it. And it was hard to get providers to really have a vision of what we were trying to accomplish. It just wasn't easy. And you know, the requirement for USCDI version 3 specifically states either in structured or unstructured fields. So that's not easy to figure out. Then there's data needed for analytics. If you look at the core purpose of healthcare reform, it's to move to a system that's outcome-based where we measure clinical outcomes. So we needed to figure out what data is needed for analytics. And then even the most important, the whole purpose of healthcare reform that put all this stuff in place is that we should be improving the quality of clinical outcomes and decreasing cost. So the use cases become very important to figure out how to narrow down this data to something that's usable and manageable. So Dennis and I basically worked together to develop another tool that we could use. And Lisa Nelson's used it. I don't know if she's going to be presenting it in anything she's talking about today, but her group with Catherine used it to some extent. And this tool that we're using in Eyecare, we're going to show you a little bit how we're using it to narrow down this data, but we're making it available at no cost to anybody that's working on anything related to HL7 if you see any value in it. But the way we're using it is the first thing we did is we looked at dry eye and we said, we knew that there was quite a bit of data just in dry eye. So the question is, what do people record in dry eye? So Jessica Heinke that's here, that was important part of this process. She was the leader of it. She brought together about 10 kind of very well-known dry eye specialists. They went through all their EHRs. They looked at what templates they'd created. They looked at all that stuff and tried to identify everything that they were recording. And it came out 56 discrete fields that were being recorded just for dry eye. And as we go into different specialty areas, we're finding there's a large number in all those different specialty areas that are already being recorded in one form or another, but very inconsistently in the field. So we came up with this tool. I'm just going to show it to you real quickly how we use it. And I've got to get into it. I've got to minimize my PowerPoint. So this is the tool that we created, and this is the dry eye part. So I've set dry eye up so you can see that. But when somebody starts using it, the first step we do is we identify with a small group what data we think they would want. And then users using it can say, okay, well, the way I use it is I use, if they click this, whatever they click here, it goes into their one. So now they can start using it by saying, okay, how would you grade a Schaefer angle? How would you, what's your target IOP that you're trying to do? So it lets them start looking, instead of us using an Excel sheet, it starts them seeing, okay, I can understand how that works clinically. And so then they can say, yeah, and then they can say, well, these are the selection that we would have. It really helped driving us more and getting more and more people to use it. We got people to use it that increased the number of items that we'd identified in our preliminary steps. So it was valuable in doing that. The problem that we ran into is when we were just doing, I'm going to show you one more step in this and then go back to the PowerPoint and go through the other slides. So if I add more data in here and I go over here to the dry eye, what we ended up doing in this is we found that there wasn't a lot of enthusiasm for just identifying data. And what we ended up having, let me go back to the glaucoma one is easier. When we ended up putting in fields, comment fields, I just can't switch back and forth and show you these easy. Concerns field and discussion field. When we put those in and we left just asking for comments about data, and we said, okay, that's the data. Now tell us, how would you use this in actual use case? If you were making a referral, is that the data you would want? And if you were accepting a referral, is that the data you'd want? And they could go in and actually look at the data. When we changed that discussion, all of a sudden we got a completely different response. And we found that people were trading information and discussion. They can talk about the case with each other. They can share that. They can talk about comments about the specific case. And they can give the concerns that the provider and the patient would have. When we brought this into the conversation, everything completely changed in how it worked. So let me close this and go back into the PowerPoint presentation. And I'll go back into presentation mode here. So this is just showing some examples. This is what we did in data. They could look at the data and see what they were looking at. And then they can share it. So this is the co-management app. So to share the data, if I created it and I wanted other providers to see it, all I needed to do was add them to the share list, and immediately they can see exactly what I have done. So if Dr. Clearly created the first case, all he did was add eye doctor to his care team, and the eye doctor brings it up. He can see everything that was recorded by this doctor, and then he can say, well, I in addition would do these tests if this patient was referred to me. And we were still at the data part. So that helped. But when we added the ability to, this is the thing, when we were just doing data, there was really no enthusiasm for it. When we added the ability to transmit how the providers were thinking about the data, that's where things really changed. When we put in these discussion boxes and the provider was able to say, okay, well, this is why I'm sending it to you. In this case, I'm trying to decide whether this patient needs a referral or not. So what we found is in the real world today, most referrals are based on the fact that the provider manages that patient until they think it needs to be referred, and then they refer it. And they refer it with whatever information they want. So there's very little collaboration when providers are in different organizations. And when you talk to the referring providers, you hear a different narrative than when you talk to the doctors that are receiving it. The doctors that are receiving the data, a lot of times will say things like, whoa, I wish I would have got that patient quicker, or they didn't need to send this patient now. There's a gap in there. We wanted to put together a system that could show that if we close that gap, we provide better care. And we're finding that that's what this narrative stuff does. That doesn't, the discussion part, letting one provider just have a discussion with the other one about how they're thinking kind of changes the whole game. And what we think is important now, we've got providers working together that are doing things that they've never done before. So what we went from when we were doing just concentrating on sharing data, from providers really not being too excited about it, to when we started putting in sort of this tech stuff of how are you thinking about the case, we started getting comments like, boy, if we could share information like this, we could do all these things that we can't do right now. We could share the patient and make sure that even before we make a referral, that we're thinking the same way, that when we transfer that care, the provider we're transferring it to already knows what we've been doing and agrees with that approach, and we can align it so it's more consistent for the patient. So the second recommendation that we're coming to from our experience is, in addition to sharing data, we need to also share that contextual information of why is this data being shared. And I think those are important. So we really come down to the fact that there's two things that from our experience we're saying is that, you know, I think we should consider that the country should consider this idea of using a supplemental C-CDA and see if there's implications of that. And then the other one is not just be focused when we get into the specialty data, especially of just the data elements, but also the contextual information that goes around that lets providers share how they're thinking and how they're managing a case, more than is you can get out of just a problem list. So, you know, when we look at this, the tool we're using, if anybody else in any other area is interested in, it definitely is valuable in identifying data and helping us understand clinical cases. And where we're going for next steps, I'm going to let Dennis hop in on this too, but, you know, we're looking at taking the stuff that we're learning and the information we're generating from using this app and looking at putting together a CDA generator, you know, trying to use it to identify cases and uses that to better align with what the EHRs are doing, maybe offering the app to other specialties if it would help progress their C-CDA use and FHIR use. And it could lead into more in-depth Eyecare implementation guide too. Dennis, do you want to make some comments?
Yeah, so the tool objective is kind of like we want to be able to allow users to easily define data elements and target them for specific CDA templates and or like an organizer, result organizer, you know, or observation organizer, observation result. And you know, we're not quite there yet, but we're getting pretty close, where you'll be able to define the data elements and you'll be able to define the specifics of how that data element should go into a C-CDA. And then the generator will take care of, you know, making that data discrete data. So it'll output the narrative and it'll output the structured data that goes along with it based on, you know, known patterns. That's it.
All right, thank you. Are there any questions for Jim and company? So in terms of the next steps, are there plans afoot for, you know, creating the generator or engaging some of the other specialties to develop use cases and such?
Yes.
And
yeah, absolutely.
If people were interested in, you know, either engaging with that work or keeping up with that work, how would they be involved?
Yeah, that's a good point. I don't think we have all the details on how we would do that yet, but so we're just getting to the point where I can expose the dictionary to a point where users can define their own settings. So I'm linking it to the value set authority. We're trying to come up with, you know, a bunch of different ways. So that's something Jim and I'll have to discuss, but absolutely, we'd be more than happy to have other people involved in trying to come up the way. And it's mainly for specialty data. I know there's dentistry, and Jim, I think you were looking at others as well. You you know, that could
podiatry in different
map
areas
it.
of-
So it's hopefully going to be a tool that you can just do some preliminary mapping. You can test it. You can put it into different templates. You can target it. It has access to the value sets that are associated. And then you can actually output a document and then decide whether that's what you want or go back and you know, adjust it accordingly. So it's not meant to be like a replacement to anything. It's definitely not going to be a replacement to any EHR. We're only talking about the vast majority of subspecialty data where there's a lot of unstructured data. And that the problem, as I've been seeing it for years, is that all of the data that's recorded, like visual acuities and refraction, that we started to put the process into structured data, there's a lot more that should be structured instead of just dumped into narrative with, you know, whatever formatting the EHRs decide, and then, you know, just sending it along, you know, as data that they can view, but they can't actually do anything with it. So we haven't really worked that out, but that's a good point. So I'm not sure, Jim, what your thoughts were on getting other people involved in.
Yeah, no, I'd love to have as many people involved as we can. I mean, there's a lot of specialties and there's a lot of stuff going on, and you know, Dennis and I doing this alone can't make much progress on it. I'm really interested in getting feedback from people on this idea of a supplemental C-CDA and what the implications are of that, because that's kind of critical. In what we're doing with this app, we can, like Dennis said, with the data dictionary, we can populate the physical exam part of it, because everything I showed you we put in the tool is physical exam stuff for the most part. But you know, we're not intending to create, we don't even in this app even have access to the other stuff that goes into a C-CDA. And the people, the EHR, because most of what we're putting in here, the EHRs are having their users create custom templates for each individual user, or just texting it in. They can't put it in the C-CDA and structured data. The best they could do is some sort of narrative dump that's not going to have any value to anybody. So it's kind of like the EHR can create the basic C-CDA. They can't create the specialty C-CDA. We can create the specialty C-CDA, but we can't create the other parts of it. So to us, about the only way to accomplish it is this idea of a supplemental C-CDA that really is emphasizing the physical exam section. But you know, that's our idea. Is that something at the previous IAT, when I asked that question, it seemed like everybody was in agreement with that, but we kind of need to make sure everybody's in agreement with that to really be able to move ahead.
Well, there's the one key, Jim, I think, is that a lot of the specialty data, you don't want it to be put into the main C-CDA because it's a lot of information overload, and you don't really
wants.
you know,
That's
not
right.
The majority of the audiences are not going to want that particular data. But if you're sending, you know, information to an ophthalmologist or a diabetic, you know, educator for the purposes of, you know, having, you know, lens replacement or, you know, laser eye surgery, and then and interestingly enough, operative note is what you expect to get back from the ophthalmologist. And so they require, you know, what did they replace? How did they do it? What were the procedures? What was the angle of implant? There's a bunch of information that's absolutely required to come back to the optometrist in order for them to get, you know, paid and finalize the outcomes that they need to track and monitor. So co-management in a lot of multiple types of specialties is actually quite common. And I think it's just not handled in an appropriate manner within the CDA structure, and FHIR for that matter, or any of them.
Lisa, I see your hand up.
Thank you. I think the pattern that you guys are coming on can be reinforced by what we're seeing in the advanced care planning space, where there are whole documents with lots of detailed information that care managers, case managers, primary care physicians work with patients on their advanced care planning, and they document a ton of stuff. But ultimately, when you want to summarize what's going on with a patient or summarize key issues for a particular encounter, you just need tiny bubbled up pieces of information. You don't want to replicate the entire deeper level of data in that module into these other documents. You want more of a collection of documents that you can navigate to get to the stuff that you need when you need to, or not be burdened by it when you just need the high level summary. And I think that as we bring more specialties, you could think of advanced care planning kind of as a specialty, eye care, dentistry, maybe physical therapy, all of these other things. We can't just keep making documents get bigger and bigger and bigger. But what we do need is collections of documents that allow us to navigate deeper when we need to go to deeper pages, almost like a website on yourself. You know,
Yeah.
that's really the direction I think we'll have to be going.
Yeah, that's a good point. I mean, in some of the certification, they did allow you to, when you're generating a document, include or exclude various sections from the C-CDA. So we, could have a physical exam section, but you're right, we might have to go even a little bit more granular because, even the physical exam, you might want to share the dry eye components because you're sending them to dry eye therapy or for diagnosis, but you don't want to share other things. So yeah, no, I think that makes sense. Yeah.
I think one thing Lisa just said was which was really helpful. That idea of collection of documents and like pulling what you need from them. That visual was really clear, and something about it kind of sparked something. I think if something like that was able to be done, like you stick with the actual standard forms that already exist, or documents that already exist, and then you're able to maybe take those documents and pull what you need from them. That sounds like a cool idea in concept. So I don't know how it would be pulled off, but it sounds exciting.
Yeah, that's perfect, man. Yeah, that's exactly it. I think if you break down all of the templates and the subsections and even break down the physical exam into small compartmented chunks of information, and so when you're creating a document, you can say, well, I want the problems, medications, allergies, but I also want the dry eye, or I also want the physical exam, and which components of the physical exam do you want? So I think that makes sense. But in some cases, like there's just going to be data that you want to pass to like an ophthalmologist or another provider of care, and they don't want the problem list or they don't need a lot of the C-CDA. You might still want to do a supplemental, but I think that is a good core statement that Lisa brought up that could apply to both sides. And you're right, multiple documents.
And I have two follows from that.
Collection.
Yeah. So you just compared the idea Lisa mentions for the collection and a supplemental. Can you clarify that for me? So
Well,
why
the
would a
supplemental
be
would
different?
just be one of the documents. So,
Okay.
and if you think about FHIR and some of the way people have, created their export, a lot of people were exporting. So when they say when you have to do a full export for the B10, a lot of people were exporting everything into the C-CDA that they already had mapped. And then they created what's called a FHIR export supplemental document, which can contain other information. And then you either link to it from the C-CDA or you export that document and they go out as a pair to complete the document. And in some cases, it's a FHIR export format, which could be a common delimited file with all the rest of the data. I mean, so for the people that did B10, they were implemented in many different ways. And I think it's something like that we're talking about with the supplemental. So the supplemental will contain a lot of information that the majority of providers don't care about or don't want to see. But then I'm also thinking that, with Lisa and then what you said before, that it's a collection of documents. So it could have a C-CDA plus the physical exam supplemental plus, and even in the C-CDA, it could have some of the physical exam in there. I mean, it supports that, right? So it's really a myriad of or a collection of documents that make up the whole patient's record, like a site map to the patient.
Okay, that makes sense too. And Lisa mentioned that as well, this site map, this website of yourself type of idea. But supplemental would be good for your cars or not good?
A supplemental would be good. It's like in the cases, it really depends on the context. And that's where I think it gets tricky, is because the context of sending data to an ophthalmologist, they absolutely need the visual acuity. They need a bunch of information that most people are not even putting in the regular C-CDA. I think it goes to both ways. there will be times you want to put some of that supplemental and just put it in the C-CDA so you can check it as a section, include it with your C-CDA, send it out as one document. And then there will be times where the provider needs a lot more detail to be able to make the right clinical decisions. Maybe there's a surgery, or, you know, like between optometrist and ophthalmologist is the most common, where there's a lot of information they need in order to be able to perform the surgery. And you wouldn't normally, or there isn't a need to normally include that in a regular C-CDA document. So you don't want to overload the C-CDAs with so much information. You've got these massive documents you're sending out to everybody, and, you know, for the most part, they're only looking at 20% of the information.
Yeah.
So it's
Okay, that
kind
makes
of like
sense.
a cross between the two and coming up with a good, you know, a good compromise, I guess.
Yeah, the way I look at it is
All right,
you
thank
sort of have.
you.
Sorry.
Jim, I'm
Look,
sorry,
let me
I
just.
have to
Okay.
quick. You got 1 minute.
Okay, I look at it as saying there's a core C-CDA that everybody exchanges just like we do now. And then, like Lisa said, you have these other documents that you would choose to take the document if you wanted it. But it would be based around a core C-CDA that everybody would know what was in the core C-CDA.
That's great. Thank you.
All right. Thank you, Jim. Thank you, Dennis. Always enlightening. I'd encourage follow-up conversations during the break if there are any follow-up discussions. But I'm going to pass things on to Lisa and Catherine and their entire cast of characters. I'm looking forward to this one.
We are looking forward to it as well. Well, good afternoon, everyone. I'm gonna, Karishma, are you gonna share your presentation, or do you want me to be the presentation person? You're muted.
There we go. If you don't mind, just for that reason, exactly.
All right, I will share the presentation, and I'm going to go ahead and do a little bit of a brief introduction. We're going to talk today to Samantha Eubanks and Karishma Patel from Health Services of North Texas. And they are a federally qualified health center, and they worked with Texas Health Resources, Jennifer Glass, and Evan Riley on how do we improve that maternal health documentation handoff. And I want to tell you that ECW and Epic Technical Support was with us the entire way, and they have been great partners. So we're going to start off by doing the clinical summary, which Karishma and Samantha will do, and then we're going to transition to Lisa and all of the students that you guys met earlier, Michaela, David, and Matthew, and they're going to talk through the technical components. So I'm going to share my screen, and you just say next slide when it's time to go, Karishma.
Awesome. Okay, so I hope everybody can, I can't see myself on this video, so I'm hoping that you guys can see me. But we're going to start off. So my name is Karishma Patel. I'm actually a physician assistant by degree, and I actually am in a role of clinical informatics for Health Services of North Texas. We are a federally qualified healthcare center out in the North Texas region, serving Denton and Collin counties. And today with me, we have Samantha Eubanks, who is our certified midwife. It is a new role to our agency. She's our first certified midwife hire. I believe, Samantha, correct me if I'm wrong, October, November-ish of last year. And so this is kind of where our story begins and where it all kind of comes into play. So I'm going to turn it over to Samantha for the first few slides.
Hello, everybody. So nice to see you today. My name is Samantha Eubanks. I'm a certified nurse midwife. Just a little bit of background because a lot of people have never heard of a certified nurse midwife. So what that means is I'm an advanced practice nurse, and the bulk of my job is taking care of moms while they are pregnant and through their antepartum time, their pregnancy time, and up to and through their delivery. So, although I am absolutely clinical and I bring not much to the table when it comes to informatics or information, I was so excited to hear what these ladies are doing, because ladies and gentlemen, because it
I believe it has the ability to really impact maternal morbidity and mortality and infant mortality. And that's something that's so important to our population health right now. It's a super important. So let's talk about how prenatal care goes, because if you haven't had a baby lately, you may have forgotten, or maybe you're someone who doesn't have children. But the way that this goes is pregnant women generally show up for prenatal care on an outpatient basis, meaning they come to the clinic. They start out with their pregnancy coming about every 4 weeks, then every 2 weeks, and then from 36 weeks on, they come weekly. And in the clinic, they will see me or one of my partners, either a physician, another advanced practice nurse, such as a family nurse practitioner or a women's health care nurse practitioner. And we know these patients, right, inside and out. We've got a amazing EMR that gives us a great prenatal record. We know their past, their present, their future. Well, their past and their present. So what we do is we have a huge prenatal record where we put all this data, and you know, and the prenatal record has things like their infectious disease testing, their diabetes testing, things that really could impact the mom and baby in labor and delivery. And our patients don't always tell us everything when they show up to labor and delivery, maybe because they forget, or maybe because they're in the throes of labor and they can't verbalize it at the time. So it's so important that we have the prenatal record when the patient presents to the hospital for labor and delivery. Now, currently there's not a widely adopted prenatal C-CDA document that has the required key elements. So what happens now is the L&D team often will call requesting fax documents. This creates delays. It creates extra work in the clinic, people searching for documents, trying to do manual data entry. So we're trying to improve upon that. Next slide. Okay, so we're going to tell you a little story about a patient here. Her name is Mamie Shell. She's 26 years old. She's a Caucasian female. She comes to HSNT for her prenatal care and prenatal determination. She's unemployed. She's on Medicaid. She's had an initial intake by HSNT staff, and it shows her to be pregnant with a due date of August 19th. She's single, she's unemployed, she has transportation, housing, and food insecurities. Her family is not supportive of her pregnancy. She does have 2 other children, but they do not live with her. They're living with their fathers. Michelle has some health issues. She's overweight. She has hypothyroidism. And during her pregnancy, she develops pregnancy-induced diabetes. So through the clinic and supporting organizations, arrangements are made for her to have WIC, food stamps, transportation, housing, and remarkably, she has made it to all of her prenatal visits, which is great. So we sent her to pre-register at the hospital. At that time, the hospital queried the national network and looked for available documents using the geofacing approach and targets healthcare organizations in the THR area. The hospital's EHR automatically retrieves the documents and attaches them to Mamie's chart in the EHR. So then comes game day, right? So her water breaks. She's 38 weeks pregnant, 11 days before her due date. She has a friend who drives her to the hospital. They arrive at 9 p.m. So then I come on the scene and I go and I assess her and I go, oh yeah, your water did break. Let's have a baby tonight. That's great. So I go and I look in the chart and there are more than 100 abstracts for this patient. So if Mamie is not my patient and I don't know her, I might not know that she has diabetes or, that she's had syphilis or hypothyroidism, things that really impact her care and her baby's care. So what I would do is I would pick up the phone and I would call the clinic and I would say, hey guys, can you fax me over a prenatal on her? Well, it's 9 o'clock on Friday night, so the clinic is not open. Answering service answers. They fax something over. So, and you can see all the ways that that could be problematic, right? So, they're faxing it over if they're open. If they're not open, it may be the morning until we can get the information. And, then there's the whole faxing it over process. From where are they faxing it to what machine? Does it get there? Does it get there in a timely way? This takes a lot of people away from their work, away from taking care of patients, and it doesn't provide the best outcome for us receiving the data that we need. All right, next slide. Okay, so our current state of affairs is this. And I've talked a little bit about this. I'm just going to go over it again. Prenatal care begins. It's documented in the EHR. In our case, eClinical works. Mom pre-registers at the hospital. EHR's queried and receives a lot of documents. Mom arrives at delivery site. There are many documents. But we cannot locate the needed information. Staff calls, try to get the prenatal records. This makes a huge impact upon the staff. They're taken away from their other work to fax a prenatal record. The fax is received. The search begins for pertinent information of this, 8 months of care that she's received at the clinic. So hopefully, of course, our child is delivered, mom is discharged, everybody is healthy and well, they go home, they get the support that they needed for formula, housing, and transportation. So that is our current state of affairs. And I'm going to turn over to Karishma to talk about what our vision is.
Thank you, Samantha. Yes, so this brings us to our passion project. Why are we here today? So our vision would be to change the narrative, right? And so we have, of course, the prenatal care begins, the documentation in the certified EHR that participates in a national network. Really what we're looking to do is, can we get at 36 weeks, a direct message with the antepartum summary progress note document sent directly to the facility? That is going to be the most efficient. It's clearly labeled. It has the data that is needed with the discrete prenatal information for the patient. Then the patient arrives to labor and delivery. They have all the information ready to go. We're not stopping patient care. We're not taking that time away from the patient. At sometimes, and Samantha can kind of vouch for this, sometimes everything goes great, right? You have that mother with child that shows up, and you have time. She's not dilated. She's not, or maybe she's dilated just 1 or 2 centimeters. And again, for those that have not had kids or don't know anything about having babies, you got to go to 10. And sometimes it takes a while, and sometimes it's like 2 minutes, and so you don't know, because there is so much unknown that goes on in delivering a baby, right? But we can all agree that these minor changes are going to result in major improvements for the query of the antepartum summary progress note in the vital information that is needed to kind of safely deliver mama and baby. And that really is the end goal, right? Maternal health right now is huge. It's on the spotlight. We really, really should be doing better. And so how can we do better? And this is kind of our vision. So at the end, the delivery outcome is going to be the same. It's just going to be a lot more efficient. It's going to be safer. And it's going to keep the providers and the clinical staff where they're needed, taking care of that baby and mama. And so at the end, of course, our outcome is the same. We want to deliver a healthy mama and baby discharge with the support that they need for feeding, housing, and transportation post leaving the hospital post-delivery. Next slide. So this project kind of started around March or so when we all got together and we kind of started looking at, well, what is the hiccup? What is going on right now? What is our process right now? And what does that look like? Because you don't know what you don't know. And again, Samantha is our first certified midwife hire. And so it wasn't like the clinicians were going to the hospital to deliver these babies. And so they're doing wonderful documentation in our EHR. And then they get to the hospital and it's a different EHR that they're using at the hospital. And to somebody like myself, I just think it's a beautiful document, just like the way they've created it in the system. And we realized, and it's kind of hard to see there, but we realized that they're all sending over as PDF abstracts. And so you can kind of see at the bottom there, there's an abstract, we've highlighted it. And so every single office visit, and again, if you've never had any kids or if you have children, you know, sometimes you can be in that clinic a lot, especially that last 2 months. You're going like weekly, sometimes every other day. Sometimes you don't know if it's a Braxton Hicks or you don't know if something else is punching you and, you know, all this other stuff, right? So, you could have a lot of visits. And so to see all of these in PDF format, was kind of disheartening to us. We didn't realize that's how the hospital was getting this data. There was no tag locator of where it's coming from, what is even in that information, right? So you click on the abstract and say, I'm looking for mama's blood type, right? And so I would have to literally click through each one of those abstracts to find when was her blood type testing done and what is it? Well, if you have a mom that's delivering and she is having any kind of complications from delivery, you are not going to click through 20 or 30 abstracts. That does not make sense. What are you going to do? You're just going to get all the lab work again. Why? Because that's the most efficient, it's the quickest, and you don't have to worry about making an error, which could be life or death in this case, right? You cannot get the blood type wrong. That's something you can't do because it really depends on if there is a injection called ROGAM that is needed for survival of baby post delivery or during the time of delivery. And so some of this stuff you can't get wrong, right? Again, this all ties to limiting time, but also efficiency, and then keeping the clinical staff clinical and not chasing documents or trying to look through hundreds of abstracts or even 20 of them for that matter at the time of need. So that's kind of where we started with this. We do want to take a moment to appreciate Dr. Starr was our medical director. This all started because he is such a huge advocate for interoperability and just systems talking to each other, being more efficient. So he is this was definitely one of his passion projects. We unfortunately lost him unexpectedly in April of this year. And so, you know, always with us, never forgotten, but we definitely want to, it was definitely a guiding force in this passion project of ours. So this is kind of why you see him on this slide. We definitely want to dedicate this project to him. So what is a prenatal antepartum clinical key element? So what would we like to see? And this is where Samantha, some of our L&D nurses, some of our OB physicians, midwives, other advanced practice practitioners that are delivering babies, what is probably the thing that you want to have on an antepartum record or a C-CDA that's you know, I think Jim talked about it in the presentation before this. You don't want too much information, right? Because you want it to be clear, you want it to be what they would need, and you want it to be efficient. And so in our antepartum clinical key elements, this is kind of what we are looking for, right? So we want the data elements to include gravida, which means how many times has mama been pregnant, para, how many living children does the mama have, EDC, so what is the estimate date of confinement? So what is the due date for this mother and baby? And then labs. So again, we talked about their blood type, their Rh antibodies, and those are the antibodies that determine if you need that RhoGAM shot or not. Group B strep, so that's a infection. That is it positive? Is it negative? That's very important to know because it's going to determine if antibiotics are required during delivery. And then you have hepatitis B, hepatitis C, HIV screening result, syphilis screening, chlamydia, gonorrhea. Again, you have some of your other STI screenings there. Super important for outcome and health of delivery of both baby and mama. We need to know those things. And then, of course, your social drivers, your determinants of health, any food insecurities, any housing insecurities, any transportation insecurities. We want that to be top of mind, right? So we don't want it to be something where we just expect that the mom's going to breastfeed, or that she has, the ability to breastfeed even, or she has the knowledge or anything like that. We want to make sure that once they leave, once they have this delivery, that they have every aspect that they can to succeed once they're home, because it's definitely those hormones come crashing down, and it's one of those things where you might have forgotten that you didn't think about something like this. So having somebody really ask you these questions during pregnancy right at that time really will be really important for the outcome past the delivery, past the release from the hospital. So what is our quadruple aim here? So the antepartum summary, we really want to tie in with this quadruple aim achievement. And what that really is we want to reduce the human resource time lost by eliminating tasks and standardizing access to the information. We want to improve the patient outcome by assuring completed, accurate, and efficient prenatal transition of care, to decrease the potential for any clinical information being lost or missed, right? So currently, like we said, if you go down to number 4, and we can kind of talk about it there again, but we want to improve the patient's delivery experience by eliminating care delivery delays. We want to improve the healthcare team's well-being with a standardized, consistent transition of care, eliminate the phone tags, the double working, the faxing, the frustrations. When you're required, or when your process requires somebody to fax you something, that requires a body, that requires somebody to know that that is what they're supposed to be doing. It also requires somebody to get that information, right? So you have to know that you have to send a fax over. Well, we have 6 clinical sites. So when you call our one main number, sometimes it can take a little bit before you get to the right person that's supposed to be faxing over the documents, or even knows what the hospital fax line is. And we have an e-fax. And does somebody at the hospital know how to check that e-fax? Or like Samantha said, are they going to different fax machines and they're trying to pull paper off of a fax machine, and so these are all things that potentially can delay the patient's care. It can duplicate the work effort, right? So we've already done all of this screening during the prenatal care, and now we're going to duplicate it because we have abstracts, and we don't want to go through 30 abstracts. Nobody's going to do that on labor delivery floor. Trust me, nobody has the time. So we don't want to go through 30 abstracts to get the information that we need to make sure that the baby and mama are going to be safe. And, fortunately, unfortunately, in the litigation world that we practice in, we can't get it wrong. We just can't. There's no room for error. We can't get it wrong, right? And so you want to make sure that something like this, having this CCA antepartum summary, is really, really not only going to improve the process for health services, which is what we sought out to do, but now we're on an international and national stage, because we do believe that it's really, really going to help standardize and improve all of these aspects on a more national level, and again, international level. So really what we're here for. And I think, Catherine, if you Yep. So there's not a widely adopted summary progress note for this document with the minimal data elements. Again, we don't want to overwhelm this document. We do have kind of a phase 2, or kind of a, what would be also nice to have on this document. And so that's things like that include, having a problem list. Obviously, we would have patient demographics and things like that. So we could kind of know a little bit more about the patient, but really we're trying to focus on what what is it, and get this started as far as the antepartum summary progress note document. It really, again, we just said that it's just gonna make the whole process user friendly instead of making it so manual and having to depend on, you know, again, a person. And if you're like me, who's headed out for vacation tomorrow, if I was that person, I would be worried that I didn't tell the person that's supposed to cover me to make sure to send over faxed antepartum records 36 weeks for XYZ patients to the hospital. And so, you know, you also want to give people the ability to kind of be human and make mistakes sometimes too. But, you know, in the world that we live in, as far as the OB world, you know, there's not a lot of room for error. And so we just want to make sure that that's something that we can try to get right. Questions for us?
Hey, this is Jessica from DHIT. This kind of just popped into my brain, but does this sort of fold into what Jim and Dennis were going over with their specialty and subspecialty informations?
Yes, Jessica. You have you are our leader conversation, and Lisa Nelson is going to lead that conversation, and we'll go into it more in depth. We wanted to make sure that at this conversation that Karishma and Samantha let you know clinically what the issues are and how it was impacting maternal health.
Yeah,
All
this
right.
was incredibly useful. The DHIT team was kind of discussing offline how incredibly useful this type of discussion is for us, because we get so into the weeds with the technical stuff. So even just walking through this this example patient story is very helpful.
Well, we thought it would be too, Jessica. And another thing that Karishma and Samantha didn't say, but Karishma kind of touched on it. We vetted this through the C-CDA work group for the Texas Health Services Authority Interoperability Collaborative, and they added a couple of more elements on here and wholeheartedly agreed that this was needed and thought that the baseline that Karishma and Samantha presented was where we needed to start. So we vetted this through our community as well.
Jessica, you teed up the perfect question to kind of roll us in. We really are blending, kind of springboarding off from the work that Jim and Dennis talked about earlier. The CDA.
Lisa, I think Richard had something that he wanted to say. And
oh, thank you. I'm sorry, Richard, I see your hand.
Hey, Lisa, just a quick question. So I think there was a mention about sending a direct message at 36 weeks of pregnancy. Is this expected to happen automatically from the HR, or is someone going to do this at 36 weeks by sending the antepartum document?
I think that someone would send it, Richard, because there's one of the things that we found is that there's a regulatory requirement for the to send an antepartum prenatal document to the expected delivery site at 36 weeks. So we want to get away from doing that via fax.
Understood. And for that to happen, the expectation is you would have the direct address by then.
Yes.
Of when you want, where you want to send it. Okay.
Yeah.
And is this going to also extend to iHub, like Commonwealth Care Quality workflows, or would this be strictly for direct?
No, I think it would extend to the other, Richard, because when they query, they need to query a C-CDA that looks and feels the same. We would want consistency.
And that is listed in our next steps. We felt like the easier transaction to take on for this this early track was a simple, straightforward direct message push. But our next step is to look at how to exchange the same kind of document through the query, the document query transactions that are available through Care Quality, Commonwealth, eHealth Exchange. Yep.
Understood. Okay. All right, that's all I had. Thank you, guys.
Awesome, awesome. All right, so back to the transition point from Jessica is we see this very much as a string of efforts that go along with the CDA management group's goal to bring specialty data into the fold. So much work was done generally, and the specialties were really left out. And the base of templates and guidance that we have available can really benefit the specialty space, but we just found that the specialty EHRs didn't really know how to apply it. So over the past couple of years, we started with Eyecare. Now we're working on maternal health, and we're hoping that within a year, we'll have somebody step up from either dental or nutrition, and we'll stay on this path. So we're going to do a brief presentation now from the technical side to just kind of get you all ready for the hands-on session that will happen tomorrow, thanks to the hard work of Richard and his team at ECW to produce one of these documents that we've envisioned and share it with the EPIC team who works with THR. So we wanted to just briefly go over kind of the technical purpose of the project and the process documentation that we've created about how we worked to get through this. And then we worked with a set of students who you met earlier today in the introductions, who helped develop the artifacts that we created. They'll briefly describe those to you, all for the point of getting you to the place where you can understand how it is that we were able to create sort of an expected result and envisioned antepartum summary progress note document, for which the ECW team has attempted to create the real thing. And during our hands-on session tomorrow, you'll see that exchange of information between ECW and EPIC, and you'll get to do some hands-on evaluation of that actual CDA document compared to the expected one that we created. And then we'll cover some lessons learned. So next slide, David. Keep going. This all started back in May at the HL7 working group meeting, where Frank Umig presented a paper that described kind of a best practice process that people should go through when they're trying to bring new data elements into the fold, add the modeling, incorporate them in additional guidance on how to share additional data elements. And this process is really important at HL7 because, as you know, we are working hard to keep up with the great progress that ONC is making on USCDI, new version every year, plus additional specialty domains in USCDI plus. And so this guidance is very important about how to do the process well and quickly. Some of the concerns about how Frank had imagined domain experts coming together with technical resources and implementer resources was that the process would be too slow or have the wrong kind of expectations of the skill sets. If you look in the top left-hand corner, there was a lot of work on early mind mapping and expecting that folks like Karishma and Samantha would be able to just sit down with us and draw out pretty technical mind maps of what these data elements were and how they related to each other. And as we got to know the clinical team, that wasn't the way they were going to work with us. They understand the data, they think about it from a clinical point of view, and we just had to come up with something different to really make it work better. And so we felt like our charter was to just do this project, a very small scale project, and then document what we did so that we could add to this conversation that's going on at HL7 about how best to take on projects like that. And our goal was really to just learn from the process, so we'll get better at it as we go. Next slide. Skip again. Thanks. This picture is a retrospective view on what we actually did. And so it shows how we started working with Samantha and Karishma and the larger teams to walk through from the use case to their key data element list. Then we worked on synthetic data, patient story, really taking it through all of that current state, future state stuff that you just saw in their presentation. Meanwhile, we had a very technical set of folks who are focused on templates, vocabulary, the kinds of guidance that's needed to speak the implementer's language, to tell them what they needed to record in the documents to exchange it. And these two worlds are a mile apart. And so what we did in the middle, because I had been working with Jim and Dennis and saw what they were creating with that visualization tool to quickly expose data elements and some of the complexity of the parts and pieces, And so we said, let's see if we can just rapidly use that tool to plug in the list of data elements and allow our clinical users to have very rapid feedback on, oh yeah, you're understanding what I'm asking for, or no, that doesn't look quite right. And so all the way through, we tried to utilize some of the tooling capabilities that got started in Eyecare to make things better for maternal health, all the way to the level of Dennis being able to use that tool to do some of the template generation that goes into that went into making that example document that we'll be comparing to tomorrow. So this was the process that we did, and we're really hoping to bring this back to HL7 in September and compare notes and learn from the work. Next slide. This effort, people were concerned about, how hard is it? How long does it take? We really didn't have to suck up that much time from the clinical team. A few meetings over a couple of months. The tooling work was easy because it's set up to very rapidly handle adding data elements and being able to render it and let people easily look and see what it looks like. And then we had quite a few meetings with the subject matter experts, and that's kind of the heavy side of the process right now. It still takes a lot of special knowledge to be able to translate and fit this information into existing templates, or in some cases, new templates where new templates are needed. Next slide. So we're going to just take you on a quick walkthrough. The students have prepared some slides to show you some artifacts that we created kind of in the order that they came into existence through the process. I'm going to turn it over to Michaela.
Okay, so this is the high-level use case that you guys saw and heard about in the previous presentation from Karishma and Samantha. Next slide. Okay, so we asked the clinicians what key data elements that they found to be important, just like Karishma mentioned in her presentation, but we took that further and also found the importance of these key data elements in a regulatory and national level. Next slide. So this is a research we did that checked those key data elements on that regulatory level. Next slide. And then we looked at USCDI Plus for those key data elements and also proved their importance there. So there were a few key data elements, but we really proved how vital they were by checking all of them at that clinical, regulatory, and national level. Next slide.
Thank you, Michaela. So the next thing we needed to do, now that we understood these requirements, was to implement them in a real life context. So on a lifetime level, pregnancy could be an event experienced maybe once in a lifetime or many times in a lifetime. Next slide. And for any one of these pregnancies, you have a lot of information, specific information that you need to collect over these 4 trimesters. Next slide. So given the clinical, regulatory, technical USCDI requirements as overviewed by Michaela, we then determined how we could fit these required data elements into data molecules, if you will, visualized by these subsections. So we laid out these subsection molecules throughout the timeline of an example mom's experience, and then for each particular pregnancy, as you can see with the between these dashed line intervals. So they're going from not pregnant, check-ins, delivery, etc. Next slide. We then also visualized each of these particular data elements within the subsection data molecules, just to get an understanding of how complex and how much volume and gravity there is within each of these blue rectangles that I put in. So for example, this mind map, this visualization is for the pregnancy status observation subsection. Next slide. And this mind map is for the pregnancy summary organizer. So now that we know, what we have and what we want, I'm going to pass it over to David for the next step of navigating the actual templates that are out there.
So in terms of the templates that are out there, we were translating the entry templates to existing language that exists to implementers. So the implementers are more familiar with the technical specifications and the template patterns that are named out and known for in the C-CDA specification. That way we're speaking the technical language from the pictures to the words and terms that are understandable to those implementers. And we're giving the implementers patterns to use for each piece of information. So what sections do these data elements go in? We're looking at the history of present illness versus the the past medical history. So what information really makes sense to have the summary at the summary level. With the history of present illness, we focus on the pregnancy summary organizer to organize and summarize the pregnancy related data. And then the past medical history as the picture of for the prior situations. In terms of the data elements, these are listed here. We were using LOINC as the reference terminology for the vocabulary and what identifiers and fully specified names and descriptions should be assigned. So you can see on here for pregnancy status, gestational age, etc. And then for the summary notes, we use the antepartum summary note, LOINC identifier, and also for progress note.
Excellent. The last couple of pictures that we have just show translating this into something that very much looks like the constraint statements that you see in CDA. So we've taken all the work that David just described about identifying specific name templates to use and helping to pick out which codes from various value sets that are in the constraints, did all of that thinking to make life easier for the implementers. And the main point I wanted you to notice on this slide is that the pregnancy section has, you can see 4, there's actually 9 clinical statement patterns or entry patterns already defined in work that's been done earlier in a supplemental guide. And we're just drawing from 2 of those entry patterns. As David and Matthew both mentioned, the pregnancy status entry and the pregnancy summary entry. And these are complex entries that have quite a few data elements within them. But there's plenty of other ones: last menstrual period, pregnancy intention next year. You can click forward to the next slide. Here's 3 more that are all about the DRH type that Jessica mentioned was so important in her life and birth and for her mom. And then the next slide has got some information about previous births. Last live birth is important. How long has it been in this pregnancy since you last gave birth? And then the postpartum status. And so my point is that even though this maternal health track this time is very, very small, we had to have it small so we could fit it in a short amount of time and have success. There are many other data elements that are waiting in the wings that could easily be transferred and shared in exactly the same methods and the same process that we've shown right now, that we're showing right now, and that you'll be exposed to tomorrow. Next slide, please. This just shows the same sort of thing, that in the past history scenario, these same patterns can be used to describe a summary view of what's been going on with a mom's multiple pregnancies over the course of her lifetime. Next slide. So this is a step that we did at the end that is kind of interesting because it doesn't usually happen at the end. It usually doesn't happen at all. We actually took the scenario data from the key data elements and we designed what the human readable might look like. We talked about this a little bit this morning about how much variation we have, and you see a lot of different challenges with what the human readable looks like. And Catherine expressed the problems when it doesn't make sense or when it's not organized so the reader can understand it. So we designed how these elements could be printed out in the human readable text area, and made sure that they made sense from a clinical point of view, that we had captured that accurately. And from doing this step, if you go to the next slide, you can just see inside each text element of each section, the human readable gets laid out. So we just threw some, what I call cleats, onto the pieces of information that the humans get, so that the cleats were ready for whoever was going to come along behind us and add the machine processable entries to just be able to tie right up to the information and cleat that machine processable version of the information right to the right human readable version. So we did that. And then next slide, we took into consideration the transport that would be used. And again, mostly our implementation guides close at the end of the document, but we took it the next step and we said these documents don't just mysteriously go from one place to another, they go by some transport. And given that we were going to test direct first, we sat down and said, let's be clear, given the document that we've designed, what metadata needs to be carried in the transaction to allow it to be smartly received and resiliently received at the receiver side. So we didn't leave anything for the implementers to have to guess about, no gap there for quality. We took all of our work, translated it into the data elements that needed to be in the XDM package, which is the typical way that the metadata travels and the payload travels inside Direct. And then we specified some functional requirements for the receiving system. So on the Epic side, we're saying the document list that gets created when this document is received needs to have some of that metadata presented to address the problem that Karishma was saying when she looked and there were 100, I guess it was Samantha who showed the picture of 100 documents that all just said abstract general, and you couldn't tell where they came from and what kind of information was in them. And so a functional requirement is to make sure that the right labels are presented in the document list to help the receivers make use of the information. So those were two kind of interesting aspects of the project that we did that were different than how design usually happens. Next slide. So you'll be seeing all this work tomorrow. If you come, I think our session is at 11 o'clock to 12:30 tomorrow morning. Our EHR partners will be there passing these documents based on our synthetic patient around. We definitely have learned some things. I know we'll learn a lot tomorrow, but there's some things that we've learned already. And one of them is that a job like this cannot be done primarily driven just out of the clinical people. They feel the problem and they know the need, but they don't have all the skills that they need to really invent the solution. That's where we come together. And unfortunately, right now, this process is still too heavily tipped on needing very specialized informaticists and standards people to be involved in order to make it work. And we think that there's an opportunity by beefing up the power of the tooling that's available to allow that work to be shifted more towards the clinical people who want to solve these problems, to allow them to be able to do more and make more progress and needing less of the hardcore standards terminologists to get involved. We think that these extra steps, the 3 extra steps that I just talked to you about, adding those to the process can do a lot to improve the likelihood of a successful outcome ultimately from the data exchange. And finally, we came to the realization that although it's awesome that Consolidated CDA Release 3 has absorbed the pregnancy status template, they had not absorbed the organizer, that summary organizer that was crucial for the key data elements that we needed. And there was not a pregnancy section yet mentioned in Consolidated CDA. And so there's some work that we have to do to kind of fold in some improvements back to the specs. But that's everything for tomorrow. I think the next slide just brings up what Richard had asked about. Do we envision a query-based kind of transport and making use of eHealth Exchange, Care Quality, Commonwealth capabilities for care providers to ask for documents? You know, if Mammy had ended up at the hospital before 36 weeks, her data still wouldn't have been there, and with that push mechanism. And so there still needs to be the possibility that a hospital could ask for a document maybe sooner than it was expected being needed, or maybe a different hospital. Maybe she ended up delivering someplace different than what was expected. They might need to be able to ask the federally qualified health center for the antepartum summary progress note. So we're going to dig into that a little bit later in the fall. But for now, we're focused on using direct and a push transaction at 36 weeks. So that's what you're going to see tomorrow. I think the last few slides are some research references we just added in there so that folks who download the slide packet, we encourage you to grab a copy of it. You have the background research as well.
Thank you, Lisa and team. That was excellent. Are there any questions for the group?
Yeah, this is Matt Davis. I just want to mention that this idea of this tooling that was mentioned to kind of take the place of a specialist or terminologist, it feels like software that I know that helps make other software. And that seems a little bit of meta, but it's the idea that with this one thing, you can make so many other things. It feels very promising. And I do agree that having something like that can take away the need for a particular person or people versus using the tool and working within that. And we already see a lot of that promise when we use tools that are designed for certification or tools that are designed for validation of conformance. So I agree with that completely.
Yeah, thanks. Yeah, big thanks goes out to Jim and especially Dennis Ball, who makes the magic happen. You know, he programs stuff into that tool that makes it possible for the entries that you'll see tomorrow to come popping out and marry up with the cleats that I put on the human readable part of the language. So it was real great advancement, and we look forward to maybe trying it out again on another specialty in the future. Keeps getting better. You know, it gets better each time.
Oh yeah, it's very exciting. I mean, I don't have to know all of the details of the technical side, but we can talk very promising, and a lot of optimism, and we can feel it. I feel the greatness of it, and I can't wait to see it.
Yeah, this is Jessica again. I'm going to piggyback on Matt's enthusiasm a little bit here. There's a word that keeps sort of springing itself to the forefront of my mind when we talk about this kind of thing, and that word is trust. The clinical teams, you know, providers, nurses, anybody that's interacting with this data, they have to be able to 100% trust that they're getting the most up-to-date information, they're getting exactly what they need when they need it. And I think, and again, I'm not clinical, but and the way Catherine's nodding, I feel like I'm making sense here. I feel like the clinical folks that are so sort of married to their faxing procedures are so just because it's consistent. You know, they work with the same facilities, the same people a lot. They're familiar with the report formats. They know exactly where on the page. It's tangible. You know, it's a thing they can hold in their hand. So definitely, as we move forward, you know, keeping the idea of make this something that people can trust, because people's lives are at stake. Not to sound dramatic, but they kind of are.
Absolutely. And I think it's
Yeah.
why we've been so inspired by the work of the data usability work group and that very large community of people who are coming together and saying, this is what's not usable and what we need you to fix so we can trust this information. And I think that's, you know, we have a great opportunity between now and August 23rd to take thoughts and feelings that arise from these 2 days and feed them back into that guide, because that's a very important artifact for our nation to help raise the bar everywhere around making data and documents that we can trust.
Thank you for the shout out, Lisa.
Tee you up for your conversation tomorrow.
Exactly.
All right, thank you, everyone. We're at break.
Great. Hi, everyone. Can I share my screen?
Yes, please.
Okay. Feel like I am back amongst a lot of good friends and colleagues, and it's very nice to be here. So let me see. Can you see those slides, or do we need to put them in full screen view? There's not going to be much detail in these.
I think they're visible.
Okay, and actually, in terms of roadmap, I thought what I would just do is kind of introduce you to the implementation guide that's going to be part of the September 2024 ballot. So I think we're a week away from content freeze. So everything I'm going to show you today is basically what we're going to be going to ballot with. In fact, the co-developer of this implementation guide, Brett Heel, is going to be meeting with FMG in, I think, an hour or so to get the final approval to go to ballot. So I'm going to basically walk you through the ballot content, and I'm going to make it seem exceedingly controversial so that you're going to definitely want to go look at the ballot yourself and see what you think. So anyhow, what we'll go over is, why did we put together this ballot? How does it relate to CDA? What kind of topics did we discuss? What are some of the potentially outstanding? Nothing was really contentious, but there were probably some topics for which I don't feel we completely reached consensus among the co-developers. Then I'll introduce you to the ballot a little bit. And for acknowledgements, you know, it's a lot of people in the room actually right now. And we were having weekly Tiger Team meetings. We had a Wednesday Tiger Team to accommodate one half of the globe. And then we had a Monday Tiger Team on the alternate weeks to address different half of the globe. And anyone that joined at least one Tiger Team call is listed here. And then during structured documents, we were meeting every other week to go over a status update, but also to try to highlight some of the more debatable topics. And we got some great feedback from some people, and I probably have forgotten a person or two here, and we'll have to add that before we publish the acknowledgements in the IG. So anyhow, I think the primary objective was the recognition that when you create a clinical document in FHIR, people are doing it very different in many different ways. And I think Lisa and others had identified just a boatload of existing profiles on bundles and a boatload of existing profiles on composition. And many of these were designed to represent clinical documents. And when you look at these, you know, they might use different extensions. They might provide mappings to CDA in different ways. And so the objective here was to create common profiles for bundle and common profiles for composition, so that at least we would have a uniform starting point for those people that wanted to create their own FHIR clinical document implementation guides or communicate FHIR clinical documents. So this was really kind of like the main objective of this particular implementation guide. One of the things that was important in the implementation guide was to support the unidirectional mapping from CDA to FHIR. And I know that you can't see this picture very well, but I'll show you when we get to the IG. We reviewed a boatload of these existing mappings, and there's a lot of mappings that are either explicit or implicit in FHIR Core, which we reviewed. And ultimately, we provided mappings that would enable going from taking a CDA document and converting it into FHIR. We didn't do the reverse mapping because we anticipated that this is the first iteration of the FHIR clinical document IG, and that over its lifetime, it's going to continue to evolve, and it may not necessarily continue to as it evolves. We can't say for sure whether or not corresponding semantics would be introduced back into CDA. So it's feasible to do a unidirectional mapping. Right now, it's feasible to do a reverse mapping, but over the course of the lifetime of the FHIR clinical document IG, it's not necessarily the case that the reverse mapping would be possible. I think in the mapping, we looked at, we included in the mapping even the CDA extensions that were relevant for the scope. And one of the things that you'll see here in the scope of the IG was that we standardized on the bundle profile and the composition profile. We didn't go into for instance, the section level semantics that C-CD is doing. We didn't define different types of sections, also the way that IPS is doing. Basically, what we tried to do was say, here's a common starting point. composition has sections, but we didn't go on to say what those sections ought to be. What we tried to do was take what the CCD on FHIR group and the IPS FHIR group are doing, extract from them what they're doing with bundles and composition, and make sure that we at least have this uniform starting point, so that other groups could ultimately evolve from that. And I think you had named this a roadmap. And so actually, the way that we're anticipating this roadmap is we'll let people play around with the FHIR R4 FHIR Clinical Document Implementation Guide. In order to achieve this, we had to introduce a number of extensions, but we're anticipating that by the time we get to FHIR R6, we don't really want to continue to have extensions in here. So all of the extensions that we added in the implementation guide were either backports from where we see the composition profile has evolved in R5 or R6, or alternatively, where we had to add extensions. We have queued up proposals that we haven't submitted yet, but those proposals would apply to the composition profile, so that by the time we get to FHIR R6, if we are to port this implementation guide over to FHIR R6, the idea would be we will no longer need any of these extensions, and we'll minimize the disruption on anyone moving from the R4 version to the R6 version because of our approach to backporting and I guess proactively submitting proposals to enhance the composition resource. Also, with respect to the roadmap, some of you may know that there's already a FHIR core profile on clinical document. And we looked at that as part of our background research for doing the mapping. And ultimately, we anticipate proposing that in FHIR R6, that FHIR core clinical document profile be deprecated, and that this implementation guide, which is a little bit more amenable to interim enhancements, that this become the FHIR representation of a clinical document. These are the kind of some of the core topics that we addressed. We had really just some great discussion. The difference here was way back when we started CDA many, many years ago, it was almost as though we were inventing something, right? But now, as we're developing FHIR clinical documents, we see that there's a world of real-world implementation experience. And so, whereas in the old days with CDA, we could kind of say, here's how we think the world should evolve, and here's kind of how we think, the vendors will find what we're doing amenable to implementation. Now we benefit enormously from real-world implementations, and having vendors come back to us, or the Tiger team participants come back to us and say, look, we were faced with these challenges, and here's what we actually wound up doing. And if you align with what we were doing, this is going to be easy to implement. If you go do something different, you potentially are going to be posing a barrier to us. So these were some of the key documents addressed. What is a FHIR clinical document? And not surprising, the definition of a clinical document aligns with the definition of a clinical document in CDA. We also had to think about, well, how does human readability and rendering work in the FHIR world? And how do we write this in such a way that we're consistent with the guidance about rendering any FHIR resource, rendering the text field of any FHIR resource. And in CDA, we had spent a lot of time defining the sender or the document creator responsibilities and the document recipient responsibilities. So we tried to do the same thing here by saying, the creator of a FHIR clinical document needs to put text to be rendered in these slots, and the person who's receiving the FHIR clinical document at a minimum is expected to render these slots, so that ideally you can receive an arbitrary FHIR clinical document and you can pop it up on a web browser and faithfully display the attested narrative. Relationship to other FHIR document specifications is kind of sort of what I alluded to on the last slide, which is even though we built this as a FHIR R4 implementation guide, we're thinking that, gosh, so many people have already done what they've done. It's not like anyone is going to be rushing to want to change their implementation guides to derive from this implementation guide. So part of what we did here was we tried to lay out this roadmap of our, how do we get to FHIR R6 and what happens when we get to FHIR R6. And so we studied a lot of the implementation guides that are out there. We backported a lot of stuff. And we, as mentioned before, we started putting together a set of changes that we haven't submitted yet, but a set of changes that we'd like to make to FHIR R6 core in order to more fully support what we were looking for in FHIR clinical documents. We talked a lot about CDA mapping, and in particular, probably the one area where we have yet to fully resolve, and we really would love to get people's feedback on the ballot, has to do with the mapping of the non-XML body in CDA. And part of the controversy there is, on the one hand, you'd like to be able to send something like a PDF document within a FHIR clinical document so that you have consistent metadata afforded by the composition resource. On the other hand, we didn't want to do anything that's going to conflict with the US core document reference capabilities that already describe how to send something like a PDF as the target of a document reference. So in the CDA mapping section, you'll see how we tried to walk that line and not conflict with US core, but also enable the ability to include non-XML, or sorry, non-FHIR-based documents such as PDFs within the context of the FHIR clinical document. This was a topic that we brought up because of the recognition that in many FHIR servers, like the Happy FHIR servers, you can submit a bundle of type document and you can store it immutably, but the native capabilities of the FHIR server don't parse that clinical document, but you potentially can convert a document bundle into a transaction bundle and then feed it to something like a Happy FHIR server, and that then will be parsed. But it turns out that the parsing is, or at least can be, very complicated, because I can send you a clinical document, and in that document I might have an observation which I sent you 2 weeks ago, right? Or I may send you, embedded in that document, I may have an observation that modifies an observation I sent you 2 weeks ago. So it's not just the fact that this document might be a revision to a prior document, but it's any of the objects within it might be revisions or duplicates of objects that I've sent you before. And so while it's relatively straightforward to receive a FHIR clinical document and just store it as an immutable object, oftentimes people want to parse these so that they can do interesting things, so that they can do medication reconciliation or a number of different actions. And so we tried to explore some of the complexity of parsing a FHIR bundle of type document. And we proposed creating this operation. And so we defined an API. I guess I would say we defined a relatively easy stage 1 operation that we think could be much more sophisticated down the road with much richer parsable semantics. And we have a number of questions in here that we would love to get feedback from. In fact, for all of these topics, you'll see embedded a number of STU notes. And even if people take the time to just quickly scan the IG, which is pretty short, and just look at the STU notes, we feel that the feedback that we would get, especially from this community, with the real boots on the ground community, would be enormously valuable. And we would take all of that feedback, and then from ballot reconciliation, we would figure out what revisions we need to do. And then finally, one of the big topics that we wanted to address was, this was something that we defined in CDA, how does document succession management work when you revise a document or potentially append a document? Way back when we started CDA, there was a medical records committee in HL7, and the medical records committee had this, one of the transactions for the V2 medical records was the ability to do not only a revision, but also to do an append. And their use case was, you know, I send something to the pathology department, I get back the pathologist report, but then 2 days later, I also get back the whatever molecular genomics report. And I want to logically say this document should be appended to the tail end of this one. And what we're finding is that it doesn't appear that people have really embraced or implemented the append scenario. People simply treat it as revision. I sent you this piece before, now rather than sending you this new piece, I just recreate the whole thing and send you a revision. So one of the questions that we pose to implementers here is whether there's still any need to persist the append use case, or whether we just collapse it down to a revision use case. And then also here we wanted to talk about what happens if I send you a document and then I say, whoops, that was the wrong patient. You know, how do I tell you that a document that I just sent you was in error and I wanted just to be canceled? So those are some of the topics that are talked about here. And again, feedback would be great on any of these. So now I'm going to just show you the document real quick. And so here's...
Bob, can you drop the link in chat to make it easy for people to follow along?
Yep. Oh, here we go. So again, I would say there's a couple of QA things, which I don't even think you'll notice when we fix the QA things. But one of the things you'll notice is that in the QA report, there's still one error. And depending on how it goes with FMG today, we're either going to just go with this or we're going to make a change. But the typical reader won't notice that unless they're really digging into the QA report. So this is largely what you'll see when hopefully you take a look, and you'll see a lot of notes to ballotters throughout this. So we describe what a clinical document is. We describe our rules for rendering a clinical document. And of course, these are, I guess, non-testable conformance criteria for rendering and creating a clinical document. And then this is a little bit about our roadmap and how we plan on gradually migrating towards FHIR R6. And then the other thing you'll see in here is you'll see the bundle profile here, and you'll see the composition profile here. And again, there's more STU notes in here. And for the bundle profile, the example here, oh, I didn't want that one, sorry, I want this one. The rendering, oh, you already fixed the rendering. We had talked to Graham about this, and he already fixed it. Just amazing. So this is a rendering of the clinical document here using the rendering rules that are defined on the homepage. The rendering also includes all of the stuff from all of the components in the bundle, which wouldn't be rendered as part of the clinical document. But this is actually the rendering of the composition text and composition section text fields here. Okay, so those are the main artifacts. Special topics, the CDA mapping topic is where you'll see, these red boxes show the scope of what we attempted to encode in this implementation guide. And again, we want it to be complementary to C-CDA on FHIR and the IPS work. We didn't delve into exactly what sections shall or should or may be present. We just said, here's a section and here's what a section looks like. And here's the document header and here's what the document header is going to look like. And then here's a fairly detailed mapping. The actual normative mapping is present in the profiles on the mapping tab of each profile. But this is just kind of like a graphical representation of the mapping. And then the mapping caveats, here's where we talk about the CDA non-XML body. And here's where we're asking people to look at this and give us your feedback and your experience on this as well. Then we have a special topic about immutable and parsable. It's just a surprisingly complicated problem. And it's possible, we're still contemplating whether this is something that we want to address in FHIR R6 core, but we wanted to highlight the issue here that you simply, the typical FHIR, now, every FHIR server is different, but from the happy FHIR servers, you can post a bundle of type document to the bundle endpoint or the binary endpoint and store that as an immutable object. But if you want to parse it, many FHIR servers can only parse FHIR bundles of specific types, like a transaction type. And so you could potentially convert a document of one bundle type into a document of another bundle type using such as an operation that we're proposing here. And now this document will be parsable. And then document succession management. Again, we talk about the replacement scenario, and that's shown here. And what we tried to do here was the examples, the formal examples that are included use all these exact same identifiers. So this would be revision semantics, and then other scenarios like addenda and entered an error. We have a special note to balloters about the addenda, about the need to persist the use case. And then for the issued an error, our question here was, we think that this is a fairly immature use case, not well implemented yet. What's your feedback? Would this work for you? Type of a thing. And then finally, what we tried to do here was assess through various IGs and through core what types of clinical document operations already exist. And we referenced those here, for instance, Oliver Egg's group in Switzerland, I think, did some really cool work on a structure map that could convert a CDA into a FHIR clinical document. And here's some details about how they did it. There's a document core operation. I think, John, we grabbed this one from IPS, just to give an example. And then we developed this new operation, convert to transaction bundle. And what we try to do here is, my own opinion is it's such a complex problem that it's premature to try to solve it. We created a fairly simple operation, which just receives a FHIR clinical document and returns to the user what the corresponding transaction bundle would be, and then the user could submit that to a FHIR server. We know that that's not really the desired capability, because that allows every user to follow different semantics when they submit documents. So ultimately, this would be behind the scenes in the server, and the server would receive a document. The server would have its own notion of how it's going to parse a document and might return back the transaction bundle as it was entered, or might return some other type of status. And so we try to lay out what the problem statement is and how this operation solves it. But we're very curious to know what implementers think of this as well. So I think, I don't know, Lisa, was there anything else you think we should show for this, or is that enough?
No, that's amazing, Bob. It's really valuable, and I just would encourage everybody to mark your calendars as soon as you get done commenting on the data usability guide. You need to be locked and loaded to comment on this FHIR clinical documents guide.
Yeah, and even if you only have 10 minutes and you just quickly look at our notes, those are again, there's really nothing controversial. At least everything in here has consensus of the Tiger teams and based on the discussions we had with structured documents. Obviously, nobody's really looked at it in detail yet, so there might be other stuff that's contentious. But probably the one unresolved issue where we took our best shot at was the non-XML body. So hopefully this is going to be a fairly quick review to give us some kind of high level input, your impressions on these things.
Yeah, and the other thing I think we can, in case the light bulb, I like when Matt says the light, Matt, this is for you to make the light bulb go off, is that we've had a group of people who've been working really hard on mapping entries from consolidated CDA into FHIR US core. And so these two efforts really fit together. And whether here's the light bulb for you, is that sections don't matter. They do matter because they create context, but there's nothing different about a section in a FHIR clinical document from a section in a C-CDA clinical document. The same codes apply, the same title applies, the same section.text applies. It's just maybe tagged with more XHTML type tags, but the tags are almost an easy direct mapping from CDA to FHIR. And so once you get this header work going, the section work is already done with all the work that we've already done. And the entries just swap out the XML sort of CDA structures for the new FHIR structures that you see Gay and Brett working on and Eric Haas working on in US Core. And so it seems like this is a long time coming, but there's really about 3 different projects that are all coming together at the same time to make it possible for us to have everything we need to be able to move from CDA documents to FHIR documents pretty fluidly.
Yeah, fully agree.
And I think that's maybe the way that you want to, if you're not that familiar with FHIR, here's an opportunity. And to also potentially think that maybe someday, as Lisa was inferring, that this will be the mode of exchange for documents and interoperability as opposed to CDA. So I don't know, that might be, and probably will be after I retire, but something to think about for you folks.
Version 2 is any indicator. I think he might be around for a while, but that's cool. We just all keep patting ourselves on the back for producing a successful standard, Any questions? I think my time's about up, but any questions about this? Then I am handing it back to, I don't know, Susan, who I'm handing it back to.
Jean-Luc. Thanks, Bob. That's some impressive work on the guide. I mean, I always laugh about myself where I get visions of pictures and stuff, and then it ends up as bullet points, whether it's in PowerPoint or the guide. But you and Brett have done a great job on this guide with that content. So kudos.
And Brett apologizes for not being here. He's making sure that all of his ducks are in a row for FMG coming up.
Good. All right. Next on the schedule, actually, it's a pretty good segue into that is Lisa. You're going to talk to us about CDA Management Group's long-range roadmap on CDA to FHIR.
Absolutely. Bob teed us up perfectly. Let me find my share screen button. Okay, so the next part of this conversation is to, I want it to go in big mode on the other screen. Give me 1 second. Which screen are you seeing? Are you seeing the PowerPoint in non-expanded or non-slideshow mode?
Yes.
Yeah.
Okay, then I just need to find slideshow, primary monitor. Go. Okay, and now I need to move my participants over here. Okay, great. So the next thing we wanted to talk about is this idea of a larger roadmap for the industry towards FHIR structured documents. And we mentioned a couple of times the CDA management group. You've met a lot of us already, Dee Dee and John and Rochelle and Linda. Kyle's here, Susan's here. But there's a group of us who are chartered with making and maintaining a roadmap for CDA and figuring out what we need to do to keep the community moving in that direction, support where we need to, run events like this, and other work. And most of you said in your introductions that this was not your first IAT. And for the amount of time that you all have been coming, I know that you have been exposed to these annual USCDI updates, the pattern that Brett and Gay are doing to come back every time and help us move that engine forward. You've heard from the group that Benjamin and John and Natalie participate on to create these mappings between consolidated CDA and FHIR US core entries. You have heard about IPS, the International Patient Summary, and that's a very interesting IG because it is universal realm, but it's sort of a universal realm version of a CCD. And they happen to have a guide in CDA and a guide in FHIR already. So work that gives us it's not officially mapped, but it gives us good patterns that you can look at between the two. For at least the past 2 sessions, you've been hearing from Jean and others about the new IG publishing tools that we've developed for creating CDA guides that use structured definition to express the templates, bring us much, much closer to having a similar publishing process and a single IG creation process. And now you've just heard from Bob Dolan on this really important work that's being done to establish profiles for FHIR that give us an exact smooth launch mapping from what we do in CDA to what we would do with a structured document using FHIR composition and bundle. And with all of these pieces coming together, the roadmap thinking that we're having to do is to figure out, so when will FHIR structured documents appear in our future? And what is that going to look like? We have a very tangible sense of this nearer term kind of marching at it quarter by quarter, year by year. But what happens when we look beyond just the churn of the annual cycle and try to look farther out into a longer range view? And this slide is a slide that we've been building over the past 7 years or so to just sort of keep track of everything that's going on in the core standards area and a couple other spots at HL7. We took V2 into consideration on the bottom of the slide. In the blue, that's their color. And then in green, it tracks what's happened with CDA from the time when we invented CDA R1 to the emergence of CDA R2, and how that's been going, along with sort of some attempts to birth newer versions of CDA, but really resistance and feedback from the community to say that they're not willing to go to another major version of CDA, wanting to stay on CDA R2. And then we've talked the past couple of times about the work that we've done to reinvigorate CDA R2 as our ANSI approved and ISO approved standard for CDA, and some of the new online navigation tools that give you easier access to that standard, while at the same time building a kind of a novel SD format of CDA R2 that enables that IG publisher technology to work. And up here, you have everything that's going on with FHIR. And you can see here, you know, we've been focused on FHIR R4 because the community that's been largely adopting FHIR for practical purposes has been working on FHIR R4, so we've focused there. Bob Dolan's work that he talked to you about is focused here, but at the same time, readying us to be able to make a jump to FHIR R6, where the community is putting their efforts now to release what is really what Graham describes as a stable sort of improvement off from here with some newer things folded in that have been worked on in FHIR R5. So we know FHIR is coming, and we know that we're doing what we need to do to get ready. What does the next 5 years, 10 years look like for us? And in the CDA management group, we've just been putting together this straw man that people can throw arrows at and agree with, disagree with, help us kind of gather your input on how far out do we see and what do we see in the future. We know that some of the regulations that are coming out now, like HTI-1, HTI-2, just based on the timelines that are associated with those regulations, we know that nothing really significant in terms of shifting to FHIR documents would really be happening until after 2028. But around that time, you know, there's room to start thinking about what would be happening from 2028 on. And so this chunk of time in here, the 5 years between 2028 and 2033, we're sort of straw man viewing a hybrid world where we are ready to exist, not like solely focused on just one or the other, but beefing up our strengths to be able to have some people maybe doing FHIR documents, some people doing CDA documents, maybe some doing both, and a gradual start of the shift so that you go from having no FHIR documents floating out there in the community to there being some, to there being more, to there being, you know, more readily a common thing. And so what we're trying to gather input on is your views. You know, I'm sure you guys are in your own businesses are looking out at your roadmaps and planning for the future, and planning beyond, you know, maybe not out a full 10 years, but if we were looking at getting the community from 2024, where we are today, to be capable enough, you know, trained and educated and ready, comfortable to be working with FHIR documents by 2028, with the idea that engineering groups would be ready to start incorporating or playing with the idea that FHIR documents would be available. Does any of this make sense to your plans, or what do you see? This is our chance to really make sure that our roadmap planning has input from you guys as our larger CDA community. Anybody thinking about it? I'll call on, if Rochelle is here, I want to call on Rochelle because I know I'm very interested in what DHIT is thinking about this, and others maybe who have some exposure to organizations that are starting to ready themselves for this. Our EHR vendors, if you guys have any views that can be shared, would also be appreciated.
Can you rephrase the question?
The question is, as you guys make your roadmaps for your own organizations, are you beginning to think about producing or working with FHIR structured documents? And what do your roadmaps look like in terms of, you know, matching up or not matching up with a roadmap that might go over a timeline like this? Do you see FHIR documents, Matt, in your future?
Yeah. And again, Rochelle would be the best to speak for DHIT, but I can speak on part of it. We definitely have already discussed the idea of supporting R6 and going in the direction of R6 for FHIR. We've been heavily motivated by 3.0.0 structured definition, implementation, as well as the actual validation tool that Benjamin and John showed on earlier IATs. I don't know what else to say except I've been using it. I'm enjoying it. I do have some questions for Benjamin for improvements as far as on my end on how I use it, but their documentation and Jira Confluence have been great in helping people like me who are more used to using the UI tools than using anything else. So those two things are definitely on our mind, R6 and getting comfortable with that 3.0.0 structured documents, a structured definition documentation.
Awesome, thanks. I noticed Ryan is still here from Epic. Ryan, do you have, can you comment at all about, is Epic thinking about FHIR clinical documents in its future?
Yeah, I don't know specifically about like roadmap plans. However, I do know that we've started development on the IPS FHIR document. So I know that we are actively working on that now. And I would imagine that, we'll continue in that space, in that direction.
Awesome, awesome, thanks. So that's sort of like R&D work now, but do you know how long it takes between sort of when you start playing with it and when anybody would ever see a FHIR document available, like to be queried for using facilitated FHIR through care quality?
I'm not sure on that time horizon.
Okay, all right. Jean, you have your hand up?
Yeah, so I'm interested, the fourth bullet point where structured doc spec should be done as both templates and FHIR profiles. I mean, if you look now at US core versus C-CDA, I mean, we're representing the same business concepts, but differently. And if I like not in a document. So it's interesting and great to see what people's support of FHIR documents, and Liz's comment in the chat is good. But is the intent that I would express potentially, if Sarah Gott's doing her NHSN templates, she'd also produce FHIR profiles that may not be in sync with US core because those are not necessarily done in a document paradigm. How do you guys see that?
I don't know. I'm not sure if the US core profiles are or are not sufficient for representing entries, but I think that that's one of the things, like the premise in the C-CDA on FHIR IG is that they don't have to create entry profiles, because when you get to the point of now this is your medication entry inside your medication section, they say go look at the US core medication profile and use that for your entries. So I think the premise is that either it will be US core profiles, or it could be a further profiling that's on top of US core profiles. I'm seeing that done. Like in our FHIR work on ADI, all of our FHIR profiles start with conformance to a US core profile, and then we further constrain a profile. Just like our CDA work starts with a template out of C-CDA and then further constrains it for our particular business case. And that's a great example where two IGs grew up completely separate, CDA versus FHIR, but in the way that the group worked at it, we'll almost be ending up with a one-for-one match between the entry templates in the CDA guide for PACP and the entry profiles in the FHIR ADI guide for type 1 patient-generated advanced care plan documents. So we're looking at maybe just bringing, as the future comes around for the CDA guide, we might choose to just merge it in with the FHIR ADI work, call it a cross-paradigm guide, and then, make our CDA templates in the new structure definition. And it's just like, you want to do this in CDA, go look there. You want to do it in FHIR, go read over there. One set of use cases, one set of business guidance, one set of, general knowledge that has to be imparted, and then just a bifurcation to say, those who prefer green, go right to the CDA templates. Those who prefer red, go left to the FHIR profiles.
So are you saying you see a future where, so currently after last IAT, I've been leaning more towards the 3.0.0 structured document implementation guide. If I'm saying that wrong, let me know. The structured document or structured definition. Structured
It would
definition.
be structure definition as the
Yeah.
format that the templates are in. Yep.
Yeah, that's correct. So structured definition for 3.0.0. I've been leaning more towards that as I continue to work through documents, work through USCDI v3. So sometimes I have the need to dig deeper into the data types. And the structured definition 3.0.0 implementation guide helps more with that than the current version, which is I think C-CDA search, where it's more HTML based in the previous format.
Yeah. And
So I've
everything's
been
disconnected. Like you want to find out about a data type, you have to go find CDAR2 and open a different guide and know how to navigate
Yes.
in a different place. Yep.
Yes, but I will say that the way the structure definition is currently working, it's all linked to each other. So if I want to click the data type, it's smart enough to take me to the CDA structure definition as well, and I can look through that. But it doesn't help a lot of the time with searching for particular templates. So I'm still using the other website in order to do that. Are you saying you're going to lean more towards the structure definition existing and the CCDA search not existing?
Right.
Does that make sense?
The CDA search that gives you like an online representation, but it's really backed by those PDF pages.
Yes.
That was what we called a bridging strategy. We wanted to get people off from downloading PDFs and struggling through PDF documents. And so for a couple of years, thanks to the generous work of John Demore, he invented a process to basically consume the PDF pages and produce that online website that just made it a whole lot easier for you to look at the templates. But that was only for CCDA, and it was only for that short amount of time. Now that the new guide has been born, and I'll just bring that up for people who may not have seen this yet, but the CDA R3.0.
Maybe you can go from one to the other. Can you do CCDA search first?
Yeah, I'll do them both.
Yeah.
Oops, that's not where I want it to be, but I'll leave that up just in case. CDA online nav.
Maybe if you go back one more time, it's the ones with the orange icon. If you do CCDA search again in your bar.
Yeah.
Yeah, look at the one that says, look the one with the orange. Yeah, that one. Yeah.
Thanks. Yeah, thank you.
There you go.
All right, so we'll compare this one
and then if you go to prototype, it'll be there.
Oh, really? CDA. Yeah. I always do this C-CDA R3.0.
That looks right. Yep.
Yep. Let me make that a little bit bigger too. So it's sort of, they aren't exactly the same. They aren't exactly the same thing because this one, the C-CDA online navigation website, is the current version CCDA 2. Well, I shouldn't say current version. It's the 2.1 version of consolidated CDA. And the technology is a little bit different. It's really a way of automating what's going on in these PDF pages so that they become more viewable, but they look exactly like the PDFs look, and they're using the information from the PDFs. As of Consolidated CDA Release 3, the guide is now published exactly like a FHIR IG. This is like the FHIR IG that Bob Dolan was just showing you. Only instead of making FHIR profiles, it's making CDA templates. And so if you click on one of these artifacts like the care plan document, instead of seeing a FHIR profile on composition, you're seeing a CDA profile on the clinical document schema. And it's telling you what fields in the header to populate. It's got your record target. It's got your, everything that you're used to seeing in the constraints of the PDF.
As well as the sections and all of that good stuff.
Yeah, and then you can go
deeper and deeper.
Deeper into all of these. Everything is linkable. So if you need to know something more about the CS data type, it brings you right to Coded Simple, and it's very, very slick. So what this has to do with this slide is that starting now, we are trying to train more people to understand how to use that new IG publishing capability, so that the handful of guides, about 25 or so active CDA guides that the industry is referencing and using right now, we need to look at how will we move them forward. At least every 24 months, they have to go through an update or they get stale. You can do stuff if you want to keep them around, even though they're getting stale. You don't have to touch them. You can use an extension process, but they're on their way towards becoming retired with no activity being put into them. And so for folks who want to keep those guides moving forward, they will get trained on how to use the new publisher capability and move their templates into this SD format. And every step of doing that brings our work closer and closer together between these two families of products. And I think it will bring our minds closer together. It'll bring our work closer together. And we're hoping that it's not too crazy to think of a time when by 2028, which is like 3.5 years from now, that we would start to see FHIR documents at least coming into existence from a few early adopters and start from there. So Matt, maybe DHIT is going to help us be some of those early adopters if you guys are planning for it already. Ryan just explained that Epic is at least looking at it in the IPS space. We know that the work on IPS, this broader universal realm sort of patient summary, like a CCD, but I think adopted at a higher level around the world. This document is also pushing us to be ready for the first, you know how dominant CCDs are in the CDA space already. And if IPS documents tend to be born as FHIR documents, that's a good reason why early adopters will start knowing how to do FHIR clinical documents. Anybody else? Kyle, I noticed you're on from Meditech, and maybe I didn't know if Richard was still on from ECW. Anybody else from the EHR space have anything you can contribute in terms of where you guys are, if you are starting with or thinking about getting started with FHIR clinical documents?
Yeah, we're definitely thinking about it. Similar, like we have work in the pipeline for IPS, and we have had this preliminary discussions regarding, other FHIR documents, but we don't have anything on the roadmap on, an outlook on when we expect to be completed with any of those.
Awesome. Is IPS picked up by the Argonauts? Do you know if that's in one of the places that EHRs are getting a roadmap view? Do the Argonauts talk about it at all?
No.
No. Dee Dee, do you have a view from Sequoia's vantage point on when you start to see, I know facilitated FHIR is already a real thing, and where do you see this going?
So this is Dee Dee, not speaking on behalf of any formal organization, Sequoia or otherwise. I think it's going to take some time. I think, you quoted me in one of those bullet points. I think we're going to have a hybrid world for some time to come. I'm not going to speak specifically on conversations with X, Y, or Z vendors, but I've had conversations over the past 4 years with the data usability work. And I'm hearing, just like everything else, there's so many things to do, and this is complex, that people are hesitant to do a whole lot more advance to CDA, but then when they see that FHIR doesn't have everything that it needs to do everything that we want in CDA, that there has to be some vehicle. So I think we're going to have a hybrid world. I do believe that there's also going to be different use cases for different transaction communications. So for instance, the vendors I'm speaking to, they are willing to speak FHIR to like patients or maybe to payers, because they're receiving catch buckets or doing it FHIR-wise. So using facilitated FHIR with an intermediary
or EHR supporting it directly point to point, I do think there's pockets of FHIR that will happen. Patient apps being one, potentially on the payer side of things for, you know, certain use cases like prior auth and things like that for sure, because those make sense in workflows. But I think if you really consider the usefulness, and we have some clinicians on here as well, it helps to have the context and information about where this data came from. And when you chunk it into pieces, sometimes it loses that provenance. And so we need to make sure that as we migrate to this new world, that we have a way to put a nice little letter inside the envelope, like we're doing with CDA. Today, you have a US realm header that gives you information on the document, that helps you slice and dice that. It's not going to be so easy doing that without having a whole, you're going to explode out. You're going to have to put provenance for every one of these resources and things like that. It's going to, you know, it's going to get more complex before it gets better. FHIR is not a magic bullet. So I don't think vendors who are already exchanging CDA provider to provider are going to change that. They may augment and improve the CDA documents, but that funnel is flowing. There's policy frameworks like care equality, like, you know, like TAFCA coming, and so forth, that are going to help inform that there will be certain things that there are requirements to follow. So I do think that this onion layer of, okay, is US core further constrains the, you know, the FHIR piece, but then what other implementation guides, profiles, et cetera, do you lump on top of that? So you need to make sure we don't get lost in translation and we have some consensus on the basic needs. So it's going to take some time. And we're trying to tackle it with our data usability work, which I'll, you know, talk more about tomorrow. We're starting to tackle that by giving some charts, thanks to Andrea Petkus. I think people have mentioned her name many a times. We showed in V2, here's what the data looks like. We need to start making folks understand from an educational perspective that the data is the data is the data. It's going to store in a database the same way. And vendors are not going to convert to a FHIR-based database, but they need to be able to package it in a transport differently. All FHIR is doing is transporting it differently. It's chunking it up differently, but they need to take and send that lab result information, receive it in a V2 message from LIS vendors, et cetera. They need to send it to other providers, other organizations that are not their own hospital system, et cetera. In a federated approach, that's CDA. There are over 900 million clinical documents exchanging across the care quality network every month. So that's what's happening in the real world. We got to improve that data that's being sent. And FHIR will just be that much more, and it'll be used for pockets, but it's really going to be more point to point, really what we would consider underneath those networks, those hospitals talking directly to an app or maybe to, you know, to payers out of the gate. And I think that's why ONC is doing their 10 by 10 project and things like that to help spur some of that.
That's why I think as well, that you don't have this hope or this expectation that it's going to overwrite anything that's already existing. It's made to integrate.
I don't think it's going to go away in my lifetime. CDAs are going to continue to exist, just like V2 messages are going to continue to exist.
Agreed.
They're not going to replace a lab interface in V2 that's already working. Why would they do?
Exactly.
So, you know, there's no in it for them. So I think we need to
where there's new work. I don't know if anybody is in the payer space to know, but you know, with prior authorization and the document templates and rules and the work that's being done to try and ease the burden of paying for healthcare and getting authorization for healthcare. I wonder if there might be some pockets there where it's stuff that people haven't been doing yet. And so when they take on something new, if they'll look at that and go, well, we should do that in FHIR because we know that that's the direction we're going in. Meanwhile, still supporting what we already do in CDA with CDA.
I think that's exactly right. And then in some cases they may find by trying it, oh no, I'd rather do it this old way. So I think as people really start
putting, the rubber to the road, they're going to start figuring out, well, this is an easier thing. Let's just repurpose this, or no, this is something so new. Let's do it this way and innovate. So, and public health is pushing it from their side as well. Remember, with all the public health modernization work CDC is funding as well, there's going to be pockets. I can tell you today, as of July, basic electronic case reporting is being sent to CDC via FHIR from specific organizations. Now it's just, maybe a couple of dozen. It's not the, 95% of the US hospitals, but there are some that are sending pockets of that information today. So I do think it's going to happen, but it's going to be slow little pockets and places.
And that's why I think it's okay, because you have some, government certifications that are expecting it. Like you say, you have ECR, which is accepting it. You have other people who are trying it out. And so you definitely are having people at least, dipping their toe into it. And so it's going to be something like I hate to oversimplify it, but like it's the same thing like a CSV, right? If I can't currently take my existing data and map it to a different type, I may want to do that. And that's what you're going to want to do as you get into FHIR, because so many other receivers are going to want it, or they are going to now accept it.
I see, Frank. Frank, you have your hand up.
Yeah, so that's quite funny. So not sure whether you have realized that every speaker touched the same topic, and I guess Didi, you mentioned it directly. So that we have to do the data transmission using different standards. So V2 messages, CDA documents, FHIR resources, whether it's a document or a data instance, I guess. The problem is we are sending around data quite a lot, and currently we have more than 2,000 implementation guides with thousands of profiles. And Bob mentions that as well, when saying, well, let's try to translate a document into resources or whatever, so whether it's entities, etc. So to identify what is it, what we have in a document, for example, as an entity, how to represent it. Is it a condition? Is it an observation? What is it? And if it's an observation, what kind of profile do we need to instantiate or instantiate data according to a specific profile so that it is represented correctly? So we are talking quite a lot about sending back and forth data, round trips, so getting in data via V2, creating CDA documents, storing it FHIR resources, and then back to send it onwards using V2 again. So the problem is that we should not or shall not lose information. And that requires us to think about what is the specific data. So what belongs to it, how does do all the details relate to each other, etc., etc. That's an issue we never have discussed. And that's totally open. So we are talking about quite a lot of different representations of a specific data, but we have never identified what is this data we are sending back and forth. And therefore, I'm heavily in doubt that we are reaching interoperability here. So everyone is doing something, so is eager to use FHIR or not, which is great. But we need to concentrate on the data and the identification of what is the semantics and relationships, internal relationships, etc., etc. And that's something I still miss here.
Yeah, and Frank, I don't know, you might be able to speak more because you are more internationally focused. I just thought about, I didn't answer the IPS part of your question, Lisa. I am following that work. I am doing it for my own knowledge. I don't see, I think there is Epic on here, so correct me if I'm wrong. I know Epic has committed to by next summer having IPS available and so forth. There is no regulatory push for an international patient summary that's an equivalent of a CCD. I've had a lot of people say, well, you need to make these policy frameworks require that. And it's like, well, you don't understand. The CCD is the same thing. We're calling it a CCD. It's a patient summary. It's a snapshot in time. And the data can be put in an IPS structure. That's not a problem. But we don't have a lot of that international information exchange. I do know I'm working not only with HL7 on this side, but also on IHE, who's going to be doing some testing around IPS at their North American Connect-a-thon in February. which will be using an IPS payload from Canada to the US. That is something that's going to be happening sooner rather than later. So I am working on following that kind of stuff, because that does also in part some policy implications that we just need to be prepared for as we think about these next steps, because I'd love to be able to have interoperability happen across, country borders. I know there's, some regulations like Patriot Act and others that people have been scared to do some of that. So we just need to try to figure out what are the barriers and pain points and trying to work on it. So I do think as vendors start, like Epic and others continue to evolve and start supporting it, we'll start seeing more of that adoption. But I don't think it'll replace what's already, kind of required. We have USCDI as our bar that continues getting raised in conjunction with, CDA FHIR or whatever.
Yeah, but Didi, that's one problem. So for example, we have the C-CDA specification, which is standalone, and we have an IPS specification, which is also standing alone. So what we are currently believing is that they should be compatible on one hand, and that they should cover the same foundation, but that's something we cannot verify. And on the other hand, we do not have a higher level specification of the data, which should be within C-CDA or in IPS, so that we can say, hey, both guides are conformant to the same foundation. That's something we cannot tell because we have never done that. So again, we have two separate specifications and we have a belief of what it is. So in other terms, they are representing data and we don't know which one.
Yeah, the devil's in the details for sure.
All right, Joginder, I might be catching us up here a little bit or getting us ahead. I don't know, unless anybody else, feels that this would be a time if you want to say, contribute something. We have 7 minutes left on this topic. Any thoughts? We sure appreciate hearing from the community. This is our time to get it. All right, hearing none, I think I'll turn it back to you, Joginder. Or Sean, I guess Sean is back.
Yep. All right. I don't know. Linda and Brett. Brett is here. Linda is here. Are you guys ready to talk about multiple types of insurance coverage? That's what's next.
I think we are. Brett, do you want to share since you're going first, or you want me to?
Sure. Let me pull it up. And remember, we go to 4:30 and we have a break.
Yep.
Yeah, and I can kind of remind people, since I was involved initially, and I don't think Brett was, but a few IATs ago, and I can't remember exactly, more than 2, less than 6, 5 maybe, we tried in one of our workshop sessions to model out identifiers for insurance cards. And our thought at the moment was that we would try to model all of the identifiers under one policy activity in C-CDA. And we took that back to the examples task force, and it was, I think the first question Brett asked was, why are they all in one? And so then we did some research, and I'll let you take it from there, Brett.
Thanks, Linda. That's a great setup. So we're talking about the payer section here, and you can hear us use coverage and payers a little bit interchangeably, and I apologize for that, but it's because in FHIR we call it a coverage resource, but in CDA that information on coverage information goes inside the payer section. So we'll get to the CDA piece in a bit. But the thinking, where Linda started with the idea of everything being in kind of a single policy activity act inside the payer section, where we started to kind of shift on that was looking at what was going on in FHIR. So a quick tour of what's going on the FHIR side of the house is Karen has created a coverage profile, the digital insurance card, and this particular project is a direct representation of what your digital, like your plastic card is. So not necessarily a perfect example to split out between, dental, vision, health, but an example of them trying to represent everything in a single profile. But where things got interesting is we started to look at the real-time benefits check profile, also out of the Caring Alliance. And if you look in here, they've actually created a coverage resource specifically with the components that you'd expect within a pharmacy benefit plan. I'll see if this opens easily here. And so when you look inside here, for folks who are familiar with the BIN number, the PCN number, the pharmacy group ID number, potentially PBM ID number, they took this and said, you know, this is a separate coverage resource. We did, for folks who are on cross-group projects, when this particular profile came forward, we did push them to use the US core coverage profile, and they said, it's just too different for us. And I think that's when the light bulb went off to say, like, well, wait a minute. If in FHIR we're looking at exposing these separately, why in C-CDA are we trying to cram them into a single slot? And so we went back and looked at the US core coverage profile. And really the US core coverage profile is focused on kind of health. You know, I would say it is really focused on the kind of the healthcare insurance part of it, not the pharmacy and dental and the other pieces. So I think where we kind of landed here is we have this C-CDA section, and we haven't quite given guidance explicitly on how to handle the different types of insurance. And the kind of proposal we're going into, and I think we've settled on this with the examples task force, I want to make sure it's with the kind of the broader community, is that for C-CDA, the Coverage Activity Act, that you have a separate Coverage Activity Act for each type of insurance.
I think
with
it's
that,
a policy activity. Brett.
Oops. Sorry, Linda. Did I use the wrong words again?
I think it's the policy activity because what
Oh, sorry.
was the coverage was when they checked it because that was a USCDI requirement, and then it would repeat the policy activities.
Thank you, Linda. And
it could be me, but Linda,
separate...
you're really faint.
Yeah, I got really faint, Linda. But it's a separate policy activity.
Is that
act.
better?
Yeah, that's better.
Thank you.
Talk into the mic. Into the mic.
Yeah. So separate policy activity act for each. Gosh, these words are very difficult. For each type of coverage. And then Linda, do you want, and we have an example that we've been working on the examples task force to kind of start to set this up. And so this is one that we
look at the other part first and then come back here. I'm
okay.
sorry, I probably should have rearranged the slides, right?
Okay, I'll let you talk through here, Linda.
Okay, so this is our premise that we believe each type of coverage, and since the word type is so crazy, I just enumerated a few of them we were thinking about. I probably should have put an et cetera there. Would be a policy activity in the C-CDA payer section. And then, so the policy.act.code will indicate the coverage type using the source of payment codes. And we have some questions about that as we go along too here, but and then we had said, or US Core had said in the C-CDA IG, that if you had verified all these policies at the same time, they would all exist under one coverage activity. And if they were not, then you could potentially have multiple coverage activities. So say you verified medical and pharmacy when you made the appointment, but then you realize they need vision the day of or something, you might verify it different. So in the payer section, you would have two coverage activities. One would contain the two policy activities for medical and pharmacy, and the other one would contain the vision policy activity. I think that's what we agreed on. Brett, you correct me if I'm incorrect. Okay.
It is, and I think I wonder, Linda, before we start poking at the profile updates, just to see how people react to this. If anyone has any strong thumbs up, strong thumbs down to this suggestion.
I would like to see a CDA that has the new stuff in it, versus what we just did 15 months ago in the IAT. That'd be nice.
I started one, I didn't finish it, but I think the next couple of slides we have will help clarify that a little more. And I don't know if there's a work group time that we could do that tomorrow if we're already filled, but I am happy to work on it if somebody wants to.
Well, I'd like to look at it and at least get an example out of this, you know, if it changed and how soon is it going to change?
Well, I believe there's no real guidance in the IG about it right now at all.
Okay.
Right, Brett? Is that?
Yeah, I don't think we have solid guidance, and I think the guidance that we produced on the IAT last time actually didn't broke the schema actually.
Yeah.
So go ahead, Lisa.
Oh, thanks. So I think this is awesome. And, you know, we've seen 3 examples now of this issue when you go to make an entry, when you go to make a clinical statement pattern, it has pieces that have to somehow be put together. And whether you have an outer observation that hangs them all together, or an organizer that hangs them together, or an act in this case that groups them together, we're seeing this sophistication of being able to kind of take elements and make molecules. And the molecules are, you know, set by this whatever context that we set over top of them. And so my only question is, what are you doing with the code in the Coverage Act so that we know that we've got one of these coverage molecules that can have multiple policy activities grouped together because they were all verified coverage at the same time? Is coverage.code? I know you notice you've said something about what policy activity act.code is, but what will coverage act.code be?
I have to go look because I was thinking about that yesterday too, and I think it is the coverage code is about coverage. Just it says something like coverage,
like a single
right?
code binding there that says that you got one of these. That's the same way it is with the organizer for advanced directives. The organizer code is like this one code that says a document exists, you need to know about it.
I mean, yeah,
It makes a lot of sense.
Yeah, that's how we identify things instead of using template IDs.
Yeah. But I'm just glad it's not a value. Like, I'm glad that it's
okay.
Seems clean to me, because now you know you've got one of these because there's a code stamped right in the coverage act.code.
So Benjamin, why isn't the name? Oh, here is display payment sources. Oh. Okay. Okay. But
So
then Lisa was getting into the type of the code for type of coverage. Go ahead, Linda. I'm sorry.
Well, I was just going to say, I was looking quickly at the coverage activity. And so these are entry relationships under the Coverage Activity Act, and they are hard-coded or fixed-coded to COMP.
Yeah, component pieces. It's no different than using an organizer. Honestly, it's really not.
Okay.
It's really not that different. It's just your outside structure felt more like an act. Mine felt like an organizer. You know, there's actually somebody making an action. I could easily turn my organizer into an act. Wouldn't matter. But you've established a complex grouping, and it makes sense.
There's some things about that doesn't totally make sense, given that you can set like the hierarchy there of which policy, and you could set it among all 4 of the policies, which doesn't really make sense. You know, if you had all 4, or if you had 5 because you had 2 medical. But I assume if you don't have it, it just doesn't, you know, it's not required and it doesn't affect it. But if it's there, you then have to look at the policy to see what the type of coverage is per se. So it's a little wonky, as is this section always has been. But let me just go through briefly and tell you what this IG is showing. By the way, this IG outlines it really well, the new FHIR representation of C-CDA. If you go in here and you look at the policy activity, immediately underneath the act, you have the ID that's identified as the group number. So that if you were doing this for a pharmacy or drug, it would be the RX group number. And then there's the code for the type of coverage. And I was looking at this late yesterday, and I was unclear what this particularly was trying to tell me. I'd been trying to fit everything into payer type, and we ran into some challenges. But then I also see attached to code is the V3 code system ACT code. And then on the ACT code is the payer type. So I wasn't sure how those two played together in the IG, in this new representation. So I don't know if anybody can address that. Like what this means if you have binding at a code and then binding at the code at code.
So it's we've bound the payer type. So it is the payer type that, because we're looking at the key elements, that's the main page. It's showing the inherited binding, which it gets from CDA, sorry. So code is bound. Okay. Yeah. By binding at the
as an
example,
example,
we're not saying you can't, you can't, oh, Benjamin, help me out there. You can't do.
Well, can you go to the differential or snapshot table? Do you see a 0 to 0 on null flavor? Because normally when we did a binding on code, it was well, I guess you're looking at a screenshot. I'm sorry.
Yeah.
Normally when we bind at code, it's because you can't have a null flavor.
Yeah, that's what I was going to say. So
if here, Brett, if you go to the differential.
Oh, differential. So many choices.
I don't think we have the 0 to 0, which is interesting. We might not have done that here.
Yeah,
I don't know why we would have bounded code if we didn't, though.
Yeah, so we tend, like when we like Benjamin was saying, Linda, when we bind at the app code, it's because we're not allowing null flavors. But
would you need to look at the snapshot to see that?
Yeah, it would show.
No, snapshot would just not show it because it's not there. I'm looking at the differential and I don't see it. So I'm guessing we maybe goofed there. I don't know. I can go look at the source, but we also don't need to hold this up.
The reason so we were looking at the payer type because that's what's in US Core. And that's the one where one is Medicare, and then if you do 2 digits, it's more specific type of Medicare, and if you do 3, it's even more specific. Yeah, it's the numeric 1 to 9 system. And the challenge around that is, for example, we couldn't find a Blue Cross Blue Shield drug benefit that we could use if we had to use that. So that is part of the challenge here, unless maybe Blue Cross Blue Shield, the way they understand PBMs, they are actually just a commercial PBM to them, and there is a code for a commercial pharmacy. So that was our debate, our still lack of understanding about how we could represent a payer type. And Brett has some questions at the end, but let me tell you the other 2 or 3 pieces, whatever it was on our slides. So the payer number goes under the performer payer and then the assigned entity code. And this was, I'm sorry, ID, excuse me, identifier, payer identifier. And it was recommended that if possible, be a NAIC number, but it can be any identifier for the payer itself. And then if you go to the next slide, actually, I got my slides out of order. Can you go one more? Go to 11, maybe. Oh, no, 10 was right. I'm sorry, Brett. So here we show that if you were doing the RxBin or RxPCN, we picked this up from our example of last time. You actually can do the multiple identifiers here. One thing Brett pointed out to me that in our initial example that we did, we were using this SDTC identified by up at the top under ACT, and it cannot be used there. It can be used here. So if this were the pharmacy benefit, you could put in the RX PCN and RX bin. We've also done a little bit of discovery work here and found that the RX bin and RX IIN, which is the new form of RX bin. RX bin is generated by NCPDP, and RXIIN is generated by American Bank Association, ABA. So it's possible, or maybe we should look further into seeing if we can get OIDs for them. I have a contact in my organization, and I asked her if they had OIDs, and she didn't. She works a lot with NCPDP, so she was going to research that and let me know more on that. Because if they did, and it was a standard OID for NCPDP and another one for ABA, then you know, we wouldn't need that SDTC identified by. And on the PCN, the person who, it's kind of like an OID in the sense that once the bin is created by NCPDP or the RXIIN by ABA, then that the group that gets it, so say OptumRx gets a RX bin number, they can expand that number and put the additional PCN digits on it. They own everything, all of the PCN identifiers, the sub identifiers. So I'm not sure how easy that would be to represent. But you know, it's that
Can't
may
you
still
just make
require
the extension more complex? So if they, you know, just like with an OID in the root, can't you make the extension part have a period and then some other additional sub part to it?
I think so. I have to look. I think they want it conjoined if you're doing it that way. I seem to remember that's what we read yesterday. But yes, that is a potential possibility that in the extension. That's a great idea. I'll take a look and see what the recommended joiner is there. Maybe a dash, I don't know. And then we went on and looked. So the other pieces of data that we were trying to place when we did this insurance card was, of course, the member ID. And that's clearly defined on slide 11, Brett. And in the member ID, it goes under the participant coverage target. And there's also a relationship here. If the relationship is self, then you're done. You've got your ID, whatever ID you put here is the ID, blah, blah, blah. So on you go. If, however, the relationship to the insured is, you know, child, husband, whatever, then you go on to the next segment, which is called, I believe it's called subscriber 12, slide 12. Participant subscriber. And then you would put the ID here for the subscriber. So you only have that participant if the patient is not the subscriber for the policy.
I'm realizing as we do this, what do folks think about us adding a table at the top of the policy activity, like a table up here with those key things? I don't know exactly how we'd reference them down below. It could be just XPath statements, but I'm wondering if it'd be helpful to just have a table up here to be like, hey, here's where the subscriber ID goes, here's the guarantor ID goes, here's where you know, what do folks think about adding that table up here?
Definitely, because
Great
there's,
idea.
you know, there's currently no real visual about this. It's a lot of, it feels like more mapping than even whatever is the most complicated thing prior to pair. So that sounds like a great idea.
Doesn't it vary though across insurers?
No.
The
I
spots would stay the same.
Spots stay the same. Yeah, we wouldn't have an
stay the
OID.
same.
Yeah. Sorry, then I didn't mean to take you off your thing. I just was thinking like all of a sudden hit me like I'm glazing over and I've stared at this with you. It's hard to keep track of it all.
And the last one we have to thank Benjamin for, because Benjamin was looking at the entry relationships, which always, I mean, they're the part of the section that everyone kind of was like, oh, I don't even want to think about that. But the one we all thought it had, or sort of understood it had, was the entry relationship for authorization. But Benjamin found there was also one for plan. So down under entry relationship is where you would put the plan ID. And that could, you know, plan ID, whether it, whatever the entity is, whether it's the RX or whether it's Vision or whatever, the plan can still go in this location.
And is that an ID or a name?
I'm intending to point to the ID.
I mean, the
But
ID goes in ID and
there
name
is a
in
text. Yeah.
How would you know the ID of the plan?
It's on my insurance card. I can't attest to anybody else's insurance card because I know that they vary, even though in theory there's a standard about how they're generated. But I can see on the top of my card, it says health plan and there's a number.
Great.
And then, but it does, I don't believe, well, I guess you do have to have an ID. I don't know what you'd put if you didn't have one. Mine has a name too, United Healthcare Choice Plus, which would go down there. Are people finding a lot of cards without plans? I mean, I know, for example, Medicare doesn't have a plan ID, right? If it's traditional Medicare anyway. So you just wouldn't fill it in. But if you fill it in, it looks like you do have to have an ID.
Who's the assigning authority
Yes.
of the plan ID?
Well, technically, you don't require one, but it would be the payer. But you know, payers, that's a foreign concept to them. The idea of an
You were
assigning
working on
authority.
an OID registry of all payers that they could put in here.
That was a requirement many years ago in the well, you all know the national NPPES, where you get your NPIs from, the lookup for the NPI. The 2 P's there stood for National Payer Provider Enumeration System. The payers fought down the enumeration of plans because they just, I think they have so many and they have other ways they enumerate them. And that got removed, just like the National Patient ID got removed from the regulation, the HIPAA regulation. So that is not filled out in NPES anymore. I mean, ever. And it doesn't sound like we're ever going to get that, some sort of a national system for that. So it almost have to support. I'm sorry.
Rochelle, go ahead.
Yeah, so is the what about like the POS versus network and that type of information? Because when I don't have plan on my card, but I do know that it's a POS network. So is that considered part of the plan? I know it's not an identifier, but they always ask what kind of plan do you have, and it's either HMO, POS. I'm just a little confused with that.
That can be defined up under type.
Yeah. Okay. So POS dental, like if it was I mean, if it's like medical versus dental, so you would say a POS dental versus a POS medical.
Yeah. I don't know if you have it open, Brett, but in VSAC, that table for POS.
I don't.
Let me see if I can. I think the problem is I lost my VSAC.
And I'm sorry if it's not, I was just trying to find,
no,
I definitely don't have plan identifier on my card.
It's a great question because it is important. I mean, it goes back to our discussion that we had earlier around the policy activity code. where, I mean, I was confused by the two values there, because one of them, the V3, which is an example, there's some really nice ways you could identify, very simplistic, that it's a drug, it's a whatever policy, right? But then if you look at the payer type, and I'm probably going to have to log into VSAC. I don't think I've been there today. Give me a minute, and then I can share my screen if you want, Brett, or you can if you need me. Here, I'll give you the link. So this is that enumerated one. And you can see, for example, Medicare drug benefit is outlined there. And there's all, the PPOs. And 72, I believe, is the commercial one. You kind of have I can't remember. The 3s are the government programs like TRICARE.
Yeah.
And, or maybe it might be, I can't remember if it's 7 or the 5s without seeing the 5 at the top. But I think 5s are Blue Shield, if I remember right. So yours would be, if it's commercial, it like mine, United, it would be 72 to indicate those are PPO.
Got it. Okay.
But you do have a good
And
point.
is a POS the same as a PPO?
No, there is a point of service.
Right.
If you put in POS, I think you'll find them in there too.
Them in there. Okay, got it.
So Linda, I know we both, 5 more minutes here. I do want to jump to kind of the last question here with this group on the call here, is like, who's actively processing the payer section with the Coverage Activity Act and Policy Activity Act, or who's planning to process this information? Oh, maybe I'll ask it differently. Is anybody on the call machine processing and storing to discrete fields the Coverage Activity Act and the sub pieces?
Mike, I have a question. Is it needed for prior auth?
I mean, they absolutely, you absolutely do need it for prior auth, but I wouldn't expect people to get that from CDA. They may get it somewhere else, right? In their
Well, if they're getting it from FHIR, they're going to get it from CDA. If it's in CDA, I can promise you that from our perspective.
Is it in IPS?
Sure.
Is it in IPS, Brett? The
Go
coverage?
ahead. Sorry, Lisa.
Is it in IPS? A payer section in IPS?
Gosh, I wonder how IPS handles coverage. It's got to be.
Because
the vendors we talk to,
travel with your insurance card. Travel with your insurance information.
Right.
In the US, though, they use 270, 271 X12 transactions to get the insurance information.
But the HIEs are going to be getting the insurance information from the CCDs because that's what they're currently collecting, right? And they're pushing to use USCDI V3, and that's where the payer information is. So it's going to be exchanged in this document, whether they decide to read it in and use it. I don't think we can dictate that. I think we just need to do the best job possible to get it right.
Well, I guess, Rochelle, the reason I was asking, like, is anybody processing today, attempting to process today? It's one of these, like, trying to get real world feedback.
Can't you have more, if no one's using it yet, but doesn't that give you more freedom to be able to make improvements and not worry that you're gonna harm somebody that was an early adopter?
Yeah, it definitely gives us more leeway, Lisa, but it also still opens questions about, how are you handling the unknown payer OID? There's a few things in there that I still think it's not as bad as I don't think we have a big hole in the boat, but I do think there's a few potential hidden leaks in this design that we're not going to find out until people start testing with it.
Brett, I do know that we parse that section. The part that I don't know much about is like how much that actually drives like in workflow and like consuming the data.
Sure.
But we are parsing those structures today. And I can look into that some more and figure out like if we're actually doing much with that and how we're handling some of those questions.
Anybody else? And I would say, Ryan, I don't think we're going to be making, some of these changes are really more clarifications and making really clear what the intended kind of sub-participants are. But, we also, as we make it more clear, we can have you give it another look,
Yeah, definitely. That sounds good to me too. I think more clarity around these templates and how to use them is always a good thing.
Yeah.
I was thinking too, from what Rochelle said, we don't have anything about networks in the payer section. What network, like the provider network that you're supposed to use with your plan. And that could be another entry relationship if we wanted to define it that way. You mentioned it said something on your card, right? About the
It says
network.
It does. It has the provider network on it. And that's a Blue Cross card.
Is it like a name or is it a number or what?
It says provider network POS. I mean, I can send it.
No, that makes sense.
So what have we got from outcomes for this session?
Add a JIRA ticket to add a table, which Brett and Linda can help develop.
Okay. On the coverage and policy activity.
Yep. I think that's one clear next step. And then, Brett and Linda to review with Ryan the kind of updated comments, and I do have to run. So hopefully that's enough. Thank you, John.
And Michael, I would like Michael to look at too, since he's been pretty invested in this.
Yeah, I really appreciate y'all time on this. It's super important for a lot of clients that are doing USCDI V3. And we really just only have that example to go by, right? So I appreciate any conversation around this, and we're willing to help with it as well.
To kind of piggyback off of Rochelle, a lot of the times we're running into clients that are referencing the insurance card itself, just like Rochelle just did. So if Brett's going to do that table, maybe something like y'all do for C-CDA on FHIR, where you have a couple of examples, couple of basic insurance cards, and then show how that maps. I think that would be great.
All right, so we're at break time. We got a 15-minute break, and then it will be Sarah and the ONC. So everyone get your questions ready. We've had some pre-canned questions that they're going to answer, and they obviously have a little bit of a presentation for us. So that'll be back at 1:45.
ONC. Oops, sorry. Okay, now that we're recording, ONC is now also officially been renamed to be the Assistant Secretary for Technology Policy and the Office of the National Coordinator. So ASTP/ONC. And then in addition to that lovely name change, just to make our name even longer, we also now have the Office of the Chief AI Officer and the Office of the Chief Data Officer. Those will move from the Office of the Assistant Secretary for Administration over to ASTP/ONC. And so those positions are actually open and open for folks to apply for them. So if anyone on the line is interested, please take a look at those. And that's our big news. So the ASTP logo will be out there. As you're looking around our website, you will likely see some ASTP as well as ONC logos out there. And please forgive us and give us grace as we get used to the new name as we refer to ourselves. So I see there is a question.
Really quick, for vendors that are ONC certified, are there going to be guidelines provided for us? Or is there any adjustments expected for website marketing material?
That's a great question. Jeff, I know that you're on. I might put you on the spot for that. For our external folks, I imagine that our comms team is working on those external facing materials. Though, Jeff, I'm not sure if you have any more recent information than I might have.
Yeah, so as far as I understand, the ONC Health IT certification program will actually maintain its current logo and its current branding and its current nomenclature. Because the ONC certification program is established in statute, I don't think any of those materials, or certainly the branding or trademarks, will be changing. So don't worry about that. And okay. If I find out differently, I'm sure we'll give folks ample notice. But as far as I know, we will be keeping all of the certification program materials and related images and nomenclature as is.
Excellent, thanks. So I think that was our big naming update. Sarah, is there one? I think I've got one additional slide, unless I'm misremembering order.
Yes, you actually have a couple additional slides, because not only do you get to give everyone the HTI2 update, there's some pictures on how people can comment. So I'll let you take that away.
Lovely, thank you. Sorry, I went to hit a different button and muted myself. So as many of you, I'm sure, have seen or been aware of, we did recently publish the HTI2 proposed rule. It was available on the ASTP ONC website in the middle of July, but as of August 5th, it was published formally on the Federal Register. So what that means is that since it is now published on OFR, there is now a 60-day comment period for folks to publicly comment on HTI2. Because that 60th day, I believe, falls on a Saturday, the comments actually close on Friday, October 4th. So we can absolutely put some links in the chat to the Federal Registrar link, so folks have that readily available. And we really look forward to receiving comments. There is, this was quite the long rule with a lot of content within it. There were updates to the certification program, including the addition of some health IT for public health focused certification criteria. There was also some expansion of the API-based certification criteria. For all of the USCDI fans, there was a proposed update to shift to USCDI version 4. And there's also some components regarding information blocking, including that new protecting care access exemption and some additional governance rules for TEFCA. So it is, I believe, on the registrar, I forget the exact page count, but it was around 1,300 pages in the PDF version. So I know it is a lot, but there are some great headers and different, kind of table of contents areas. So you can pick your most favorite topic and do a deep dive into that. Or if you're super ambitious, read the whole thing. But we really look forward to receiving those public comments. And again, that end date is October 4th. Thank you, Jeff, for getting that link out there.
Thank you so much. I was just gonna say I'll put the link in the chat, but Jeff beat me to it, and it's available now.
And I will also add, sorry, just before we move to USCDI, there are also on our website, and we can grab the link for that as well. There are some recordings of information or informative webinars that we have done both on the rule as a whole, which was just a high level overview with some highlights of the content. And then we did do a few deep dive webinars, one on the public health criteria, one on information blocking. And I think one is still coming up. So the ones that have passed, the recordings are available on their website, and then you can still register for the one that has not yet happened. So we can get that link in the chat as well.
Thanks so much, Molly. We'll briefly talk about USCDI final V5, because I know Brett took us through some of the modeling for CDA, some of those questions already, and took a look at the 16 new data elements and the 2 new data classes. I think we also earlier in the day previewed for everyone that the comment period for USCDI v6 is now open, and that is open through Monday, September 30th. So this is the comment period in which you can go on to the on-deck submission system to propose new data elements. And then we also encourage community comment on the existing data elements, either the ones that are already on one of the USCDI tabs, or if you go to our USCDI webpage and see the tabs for levels 2, 1, or 0, you can go onto those data elements and also leave comments there. And I'll just pause for a moment and ask Al if he'd like to add anything about USCDI v5 or our open comment period.
Can you hear me?
Yes.
Actually, I really don't. I mean, this without diving all the way in, without diving all the way into all the details, which we will do in various settings over the next, I don't know, couple of weeks and months. You covered it. You can start your submissions for new data elements starting now, and make comments on previously submitted data elements for further consideration.
And we really do look forward to those comments. We're looking for that feedback. We're reading all of it really carefully. So hoping that people will leave their comments on existing data elements and submitting the new ones through the on-deck system. And I can put those links in the chat while we switch to talking about USCDI Plus, which was also discussed a little bit earlier today, and I'll hand it over to Liz.
So I'm going to apologize in that I didn't hear what was discussed earlier today. So if what I say now still leaves some questions, feel free to ask. So just wanted to talk a little bit about USCDI Plus. We talked about it at the Connect-A-Thon. We've talked about, there's been a lot of conversation. There was conversation at other events throughout the year. So I just wanted to, help level set for everybody what USCDI Plus is and what we're doing. So USCDI Plus builds upon the foundation of USCDI. It does not negate it. It doesn't shift focus at all. It really builds upon the foundation that USCDI sets. But it allows us to do deep dives into specific subject area domains. You could see those reflected here in order to really meet those needs. And sometimes that means, looking at defining new data elements. Sometimes that means digging in to understand what are the specific value sets that need to go into an IG, and how do we communicate where data needs can be used consistently, whether that's FHIR or another data model, including C-CDA and some of the others that are out there. So we are really looking to ensure that data are harmonized, first and foremost across across government, federal partners, but also crossing into industry partners. So a lot of our initiatives do a lot of really deep community building across our industry partners within each of those domains. And then we also apply the processes that are established in USCDI that Sarah just talked about. And we have similar processes for USCDI Plus. For example, we publish a draft data element list, and then put it out for public feedback. So currently on our USCDI Plus platform, and I'll put a link in the comments, we currently have a draft data element list out for public comment for cancer registry under the USCDI Plus cancer domain. And then again, we are always looking to leverage existing work, existing programs and authorities across HHS to drive adoption, existing standards that are already out there within the HL7 community. For example, again, in cancer, we're leveraging MCODE and working with both Codex and Vulcan in order to, drive some of those conversations. So I hope this helps. I hope this gives you a little bit of an overview of what we're doing. And again, if you have additional questions, please put them in the chat. And Sarah, I hand it back to you.
Thank you, Liz. We're gonna take a moment to talk about updates to the C-CDA testing tools that ONC hosts. We have some information for you, and we also will move into our discussion section after this. We are going to try and split our discussion up into first talking about updates to testing tools. I know in April that was a big bulk of the discussion. And then also holding some time and space for those more general questions that aren't directly about testing tools after that. So depending on how many questions people have. And Lisa has a question before we shift topics, maybe about USCDI Plus. Absolutely. Jump in, Lisa.
Thanks so much, Sarah. Molly, my question is for you around this picture. As data elements come into, for example, the maternal health USCDI Plus space, and we put comments on them, do they then head for USCDI level 0 and then climb their way up until they become one of the version of USCDI? Is that their pathway to be born?
It really
do they have a different path?
Yeah, it really depends on the nature of the element and the related, it's not a simple, straightforward path, and it isn't necessarily meant to be a path to USCDI, although that is one potential outcome. A lot of the data elements in USCDI Plus in maternal health, for example, actually come out of the level 0 in USCDI. Like it may be too granular of a concept or too niche of a concept for USCDI, but it absolutely needs to be there for exchange of data for maternal health. Whether or not it ever makes it into USCDI there are many conversations, there are many things that would determine if it would be, and it's not really appropriate to say, yes, a data element that's in USCDI Plus will become USCDI. It's not that type of relationship.
Go the other way. It sounds like it might even go the other way. Somebody comes and recommends a data element into level 0, and you're like, too niche. It's not going to be mainstream. It needs to head in the direction of one of these specific domains, and then you move it the other way.
It very well may, but again, it's not a set path. It really is a decision on an element by element basis, and understanding, where is the adoption, where is it needed, how is it getting used, there are just a lot of conversations around it. It's not a straight path either way.
Okay, thank you.
Thanks so much. There's some conversation in the chat. Jeff, do you want to jump in now, or do you want to let Aaron talk a little bit about testing tools before you jump in?
I can just quickly kind of address Lisa, I think your question on when USCDI V6 or V7 or V8 or V25 will make it into regulation. And that is really kind of a to be determined scenario. I think what you saw with the, I guess, kind of introduction of USCDI V1 as part of the CURES update, and then what you saw with HTI2, with HTI1, you saw USCDI V3 being proposed and then finalized. And because HTI2 came quickly on the heels of USCDI V3, we proposed V4. And so, I think one of the things that we're trying to do is establish a regular cadence for USCDI versions. And that also includes a regular cadence of standards version advancement process. And what these policies are meant to do, big picture, is try and give industry some notice and some foreshadowing of where we might go when the next regulation comes around. So while I think the regulatory cycle is actually highly variable, and I think if you look across the history of ONC regulations, you would notice that ONC has rarely put out regulations this quickly. I think you'd have to go back to 2010, 2011, 2012 to see when ONC came out with 2 regulations within 2 years. Generally speaking, we're working towards trying to iron out and have a regular cadence of regulations, and that would be, that would mean likely a more predictable and regular update of USCDI versions, but we can't require the use of USCDI versions unless it's through regulation. So it kind of raises the floor. So it could be another year before a regulation comes out. It could be 2, it could be 5. So the regulatory schedule is somewhat variable. I hope that answers your question.
Does that mean that there might be some hope of catching back up? So if the regulations are slow and unpredictable in terms of the how spaced out they are, that if HTI2 isn't scheduled to take effect until January of 2028, and that could potentially support USCDI V4, by the time we get to January 2028, we're already going to have like USCDI V6 published.
Yeah.
So could you slip and say, actually, HTI2 is going to be born requiring USCDI V6, more like what is the current published version of USCDI around the time that the regulation is born?
Yeah, so unfortunately, the answer to that is no. We would never be in a position to require industry to adopt the current version unless people knew what that current version was during the notice and comment rulemaking period. So in the scenario that you described, if we were to finalize HTI2 as proposed, then we would have USCDI V4 in 2028. And as you mentioned, we may be at version 6 by then. If we were to have another regulation in 2028, then we would be in a position to propose whatever USCDI version was current at the time. And then as you likely realize,
so
there's got to be an implementation
out. It just keeps slipping out further and further. So then V6, even though we could be looking at it now in 2024, the chance of that thing becoming real in production use is like 2030. Once you expand the lag time to the regulations, and that you can't talk, you have to put the regulation out in draft form, and you can only do whatever's currently published at that time, and then you got to leave a big lag time before it comes up. It just feels like we're constantly being lapped. So work that we're doing today in 2024, it just feels like it's getting further, and we're cycling faster and the regs are going slow. And so the pipe to when something becomes real just keeps getting further and further and further away.
Yeah, no,
Sure,
I
understood.
understand that completely. I think just a couple other comments on that. I think the regulatory approach to this space is a double-edged sword. And I think you have to kind of acknowledge that first and foremost. In order to require by law that everybody across the country use the exact same standard, we have to go through regulation. And just unfortunately, the regulatory cycle is slow. I think the other thing to think about, though, is that when we propose the next regulation, whether that is in 2026, or sorry, whether it's in 2028, or whether it's in 2030, we will propose the latest USCDI version, more than likely. So if we're at USCDI V9, and I don't have my calendar in front of me, but if we're at USCDI V9 in 2030, like that's the most current version, then, you know, that's what we'll propose. And, you know, from a regulatory baseline perspective, that will mean going from USCDI V4 to USCDI V9. So I fully appreciate kind of the dynamic that you're describing in terms of USCDI cycle being ahead of the regulatory cycle, but that's why we try to create some consistency. And if there's a developer out there who, for instance, decides they're not going to pay attention to USCDI versions, they're not going to use SFAP to update their technology, they will have a pretty large leap to go from USCDI version 4 to version 9 in my hypothetical. And, you know, so we work with developers, we try to promote the advancement of standards, and we try to create some consistency through USCDI version updates and SVAP, because we can't create consistency in regulation.
Mm-hmm. Yep. It is
Thanks,
what it
Jeff.
is.
And
Thanks for the
just to call out Alex's comment in the chat too, I know SFAP certainly is an optional process, but that was the program put in place to attempt to fill some of those gaps between the regulatory cycles, just given our hands being tied with many of the timing related aspects of the full regulatory world.
Great questions and great discussion. Anything else before we move on to our next topic? All right, Erin, I'm gonna let you talk about the tooling update.
Sure thing. Good afternoon. My name is Erin Little, and I am in the Tools and Testing branch. And I'm just going to talk briefly about updates to site. So we are in the process of implementing user interface improvements for site. So site is getting a facelift. It's going to be more of a hub for our testing tools at ASTP, ONC. So just a little background, we conducted user experience research interviews with a select group of ATLs, ACBs, developers, and users, just to kind of figure out, you know, what they would like to see in the tool in terms of, you know, usability and ease, and just to get some feedback. And so there have been a series of front-end updates that includes more visual feedback, because that was one of the points of concern. It's confusing sometimes, I guess, when moving from one section to another, or when you're in the midst of testing, they wanted more feedback during the process. There are also more in-depth descriptions for the tools. We've enhanced error messages with more added context, ensured consistent functionality, and also push update notifications and changes to the system to users. We're also in the process of updating documentation that will reflect the UI changes, and overall be better equipped to handle increased user loads and have better performance. And this is front end, so the functionality is still the same. So it'll look different to a degree, but the way that you use site and ETT now does not change. You still validate the same way. It just looks a little different. These UI improvements are scheduled for release October of this year. And so we will be sending out communication soon so that folks can start preparing for these new updates. And segue the conversation for SFAP. So USCDI V4 was introduced as an approved SFAP standard this June, and updates to site that include any of these CDI changes. Did someone say something? Okay.
Someone sneezed, I think, so bless them.
Oh, okay. I thought someone said question. Okay. So yeah, we're making updates to the site C-CDA validator, and including all of the updated elements in USCDI V4, as well as updating the test procedure documentation associated with the validator for all of those V4 updates. That's all I have. Thank you.
Just one quick comment on that. I was trying to use the site. Interesting, you mentioned the C-CDA validator, and I am not able to today anymore.
It's no longer up.
Yeah, it basically, sorry, it's no longer up?
You're talking about the API or no?
Yeah, it's getting access denied on the API.
Yeah, so the APIs, well, they can speak to that. A lot of the APIs, it seems like, have been taken offline, and they expect you to basically host it yourself. But can you speak to that a little bit, please?
Well, interesting enough, though, I was just using it a day or two ago and it was fine. It just, it seemed maybe it's going up and down all the time or something then.
I wonder, yeah, I think if Molly was just speaking, maybe she can speak on that.
If you're having an error, I would have to, this is Erin. I don't know if anyone else on our team has something to speak to that, but I can look into that for you if you're having issues. I'll put my email in the chat.
Yeah, I can submit it through the proper process. I just thought maybe something might have been going on, that's all.
And no, I haven't gotten any notifications of the validator being down today, but yeah, if you could do that, that would be great, so we could have some documentation.
I can help out too a little bit. Dennis, if you like, if you put that link in the chat. And thank you, Erin. Sorry for the name mix up.